This conference will now be recorded.
Okay, hello everyone. My phone says it's 10 o'clock. We've got people signing on still, so before I hand it over to Kara, I'm just going to run through a couple announcements and go over the agenda and that sort of stuff to give people time to sign on. First of all, I want to just do a couple thank yous. Thank you very much to the TFM board for helping put this thing together. The board support has been invaluable. First in planning the actual real life conference, which we had to cancel, and then quickly pivoting to this. I'd especially like to thank the committee that helped with this. That included Libby Stern, Cindy Powers, Missy, and Ken Fletcher. In particular, Chris Franklin and Sue Franklin also helped quite a bit, and Stephanie Vanderkoy. So thank you very much. We could not have done this without all of their support. Second, I'd also like to thank the tobacco section at the Department of Health and Human Services for providing most of the funding that makes this event possible. And also just for the great work they're doing. I know they're extremely busy these days, as many of you are. And third, I'd like to thank all the TFM members for providing the rest of the funding that makes this possible. And we're able to make it a free event this year, thanks to the virtual nature of it. If you are not a member, I would urge everybody to become members. TFM relies heavily on our members, both organizations and individuals. The link is there. I'd also be happy to talk to anybody if you have any questions or concerns about how to get your membership status back up to date, or if your membership is current, I can look that up for you easily. And finally, I'd just like to thank all of you. This is a very busy time for all of us, especially those of you that are working on the front lines in the healthcare field. I had a number of people regretfully decline having to come here today because they're out doing COVID testing. So thank you for taking the time to come and join us. This, I think, is going to be a very good event. We have over 175 people signed up for it. We have 100 on the phone or online already, which is great. So thank you very much. And my final thank you is to all the presenters. You do not want to listen to me for 5 hours. But luckily we got a very strong lineup that the morning's going to be sort of talking about the state of the world. Karalyn Kiessling from the University of Michigan is going to start us off talking about vaping and the links to COVID. And then Jared Burkhart is going to give an update from the legislative alliance that TFM is part of, called keeping my kids tobacco free. And then we'll have a lunch break. A number of you have asked about lunch and how that's going to work. Very few people filled out, requested specific rooms for lunch. So what I'm going to be doing is I'm going to share a bunch of links to smaller breakout rooms. You can go in there, turn on your camera, sit around, just eat lunch with people, or just go home and, or stay home, but go to your kitchen and eat lunch there. But there'll be a chance for some smaller one-on-one conversations, completely unstructured. And then after lunch, we will be returning for a couple of sessions to talk about how we can still be effective in the new normal with social distancing and disruptions to workflows and all that. So that is for the agenda. We also thank you to Stephanie Vanderkoy for helping us get continuing education credits for those of you that need McBad credits or social worker credits. We can get those. All I need to do is get your email. So if you have not registered, please take a minute to go to that link and register. And then afterwards you'll get oh, I'm sorry, I'm seeing the comments about there's background noise, so I'm going to go to mute everybody. Hopefully you guys can still hear me.
Probably.
But yeah, so if take a minute, go to the form, fill out the registration if you have not yet, and then you'll get a follow-up email to talk about how to get the continuing education credits. With that, it is a couple minutes after 10, so I'm going to pass it off to Kara. I really appreciate Kara coming in and talking. I got the chance to meet Kara shortly after starting at Michigan. Went down to University of Michigan, met with her and Cliff Douglas as part of the Smoke-Free Law Project, and was very impressed with everything that they are doing and looking forward to this conversation. So I am going to pass it over to her, and we can get started. If you do have any questions, please use the chat box over on the right-hand side. I'm going to try to, it looks like people are still getting feedback, so I'm going to try to figure out how to make sure everybody gets back muted, other than Kara, obviously. So with that, Kara, I am going to find your name and pass it over to you.
You're down.
All right, well, hopefully everybody can hear me now. And if you are using a personal cell phone or calling in, please mute your device because we are hearing you don't come in automatically muted. So if you could please correct that, that would be wonderful.
I've been talking because
All right. Well, thank you, Paul, for your introduction, and I'm looking forward to sharing what I have kind of compiled over the last week or two on what there is going on in tobacco control research regarding COVID-19. So, as I'm sure you've seen, there's been a lot of headlines about potential dangers of vaping or smoking. There's been some more in-depth analyses through the media trying to kind of get at this question. The basic answer, summarizing all of this, is that we just don't know yet. There isn't a lot of evidence out there. So while there's been recommendations made, they're not quite on firm scientific ground yet. So that kind of leaves us wondering what is really going on. So before jumping into things, I wanted to give a brief outline. First, we're going to go over what we know, what scientific evidence is actually available. Then we'll talk about what we don't know yet, specifically and identifying questions that need to be answered before we can actually see any relationship or know if there is a relationship. And then I'll talk about what's being recommended by health organizations and sort of what is the recommendation right now for providers, for health educators, etc. And then that ends the formal portion of this, where I will be talking to you, and then I'm hoping to hear about your experiences and what you've been dealing with. All right, I just got muted, so I'm not sure what you heard last, but we'll talk about your experiences hopefully, and then also future directions for research. All right, get back into the presentation. All right, so first let's talk about what we know. What does evidence show us recently? First, we'll start off with the most solid evidence that we have, which is that cigarettes are linked to many adverse health conditions. We know this. Not only is it related to cancer, but also diseases of the respiratory system. It weakens your immune system, and it can lead to poor wound healing. All of these things combine to create a strong possibility that this could increase your risk for COVID-19 or increase severity if infected and you are a smoker. So another interesting factor is that smoking has been identified in a recent systematic study as a risk factor for influenza as well. So your likelihood of getting influenza is increased if you are a smoker. So this adds to the additional thought process that if you're a smoker, you could be more likely and more at risk for COVID-19. Vaping, we have less information because, of course, vaping is newer. So let's focus on what studies have shown. So there's been a few studies which have shown a higher risk of respiratory infection for vapers, a weakened immune system for vapers, and so that kind of goes along with the idea that vapers could also be more at risk, similar to smokers, if there is problems. Additionally, there's early evidence just coming out that lung disease, independent of the effects of concurrent smoking, dual use, is also shown in vapers. So that could be problematic, as well as heart damage caused by vaping alone, which is very similar to the heart damage that you see when people smoke. So these are early studies, only one study each for those, but it kind of is building up an evidence base that shows that there might be some more damage associated with vaping than we previously thought. Lastly, a study in mice showed that there was increase in blood pressure, potentially having implications for hypertension in humans, but that was done in mice, so that's very preliminary data, and we need to see if there is the similar kind of connection in humans as well. Another specific factor that has been of concern is, of course, the e-cigarette or vaping product use associated lung injuries, the VALI. So while this has been decreasing steadily since September, there were over 2,800 cases of this in the last year. So these people could be more at risk due to their existing lung damage. There could be people still out there who we don't know yet who have damage in their lungs from using vaping products that we don't have not yet come into contact with. So that increases the potential that vaping and these injuries might be putting people more at risk for coronavirus. Especially one study recently said that there appears, rather than just the acute EVALI that we were seeing, there could also be longer term effects that we're noticing from this same syndrome. So that is definitely something to keep an eye on during this time. Before we get into some of the more technical material, I wanted to give some definitions. So SARS coronavirus 2 or SARS-CoV-2 is the virus. That is the name that the virus has been given, and it causes COVID-19, which is the disease. Although, I'm sorry if you heard my cat. Although COVID-19 is mostly what I'll be talking about, the actual disease, there are some studies specifically on the virus that I wanted to talk about. So I wanted you to kind of know this name before I showed it to you. One of the risks of coronavirus spreading is that it could be through shared objects. And that's one of the reasons that has been given that vaping or tobacco use could also be problematic for coronavirus. So a systematic review of other human coronaviruses, so not our novel coronavirus, but previous coronaviruses that have gone through, like SARS, et cetera, have been seen to last on materials for up to 9 days. So that gave us some initial idea of how long these can last. A more recent study, Van Dormelen et al. Says that it's more like 72 hours after virus is on these surfaces that it can last. And you can see on the bottom of this slide that for cardboard, stainless steel, plastic, the red data points are above the blue data points, and that shows that the novel coronavirus, SARS-CoV-2, is actually staying on surfaces at a higher level, more virus per unit than the SARS outbreak from 2003. So this shows that there really could be some issues, especially for people who are using reusable vaping products or water pipe tobacco, if you're sharing these, but also just use over days. Additionally, smokeless tobacco is also a potential for exposure because as people are chewing tobacco, they of course spit it out, and when you're spitting, that increases the likelihood of aerosols or other things of that nature getting into the air and potentially causing infection in other people. So now we get into the evidence that is a bit less clear. There seems to be in the rest of the literature 3 conflicting conclusions. The first is that smoking or vaping increases risk. The second is that these factors are risk neutral. They don't make it more likely that you have increased severity or more likely that you'll get the disease. And the last theory is that nicotine is actually a protective factor. So we'll go through each of these, and this provides sort of a framework for the rest of the available evidence. Systematic reviews and meta-analyses are really usually a good source for us to know whether something is harmful or potentially protective. But of course, the available studies right now, the 3 available I'm showing you, are relying on very few studies, and all of these are studies from China, which are basically case studies. So we don't have very good information, and they all came to kind of different conclusions. So the first found that active smoking was not associated with severity in the 5 studies they used, whereas the latter 2 studies, which focused on slightly different studies from China, came to the conclusion that it's most likely associated with negative progression and outcomes, so increasing the severity of the disease. So right now, the systematic reviews and meta-analyses are not conclusive and don't provide very good evidence for whether there is a relationship or whether that relationship is positive or negative. So let's go over some of the other information that may lead us to believe smoking or vaping increases risks. In addition to the studies we just mentioned, there was also a CDC morbidity and mortality weekly report, which came out recently, showing that underlying health conditions were more likely to be in COVID-19 patients. So some of the diseases that they mentioned along with this, such as chronic lung disease, cardiovascular disease, we know are associated with smoking and could potentially be associated with vaping as well. That leads us to maybe think that this could increase risk. The CDC morbidity mortality weekly report that reported on this also looked at smoking status though, and they did not have enough evidence to tell whether smoking status had an impact. So really from their study, it's just the underlying health conditions, and they did not have enough information on the smoking status. So still, we're waiting to get more information on that. Additionally, in other countries, it has been reported that there are gender-based differences in COVID-19 outcomes. For example, in China, the men and the women were equally likely to get coronavirus, but then once they were in the hospital with the disease, men were more likely to die from the disease. So the reasoning for that is unclear. It was suggested that smoking rate could be a difference that explained that differential outcome for men and women, especially because the smoking rate is so gendered in China as well as Spain, where they also noticed these gender differences. So this is also an area to keep an eye on, as this may indicate that smoking rate is attributing to COVID-19 outcomes, but it's also possible that there's another factor that we don't yet know of, and it's really just a theory that has not been proven yet. Lastly, there was a study that showed history of smoking was associated with pneumonia progression in COVID-19 patients. So that is another indicator that the severity of disease may be impacted by smoking status. So one of the possible pathways that has gained a lot of traction over the past few weeks has been this ACE2 receptor pathway. This has pretty much been shown to be the way that coronavirus gets into your body, into the cells. So in addition to knowing this is the way that coronavirus is accepted into cells, there have been recent studies that show smoking can upregulate this receptor, making it more likely that there are more receptors, therefore it might be easier for coronavirus to get in. Additionally, current smokers and those with COPD in another study were shown to have increased expression of these, so actually did have more receptors in the lung, which could bring in the virus. It's not very clear because there's some conflicting evidence in this area though, because another study suggested that former smokers might be most at risk. So this is still being determined, but there is some evidence that smoking may increase these receptors, therefore make it more likely that infection occurs. But it's also unclear how inhibitors of these receptors will interact with that. And ACE inhibitors are used for things such as hypertension and a lot of other common treatments, things that go along with smoking and outcomes as well. So it could go a lot of different ways, and looking at the recommendations in this area will be important as more information comes out. Smoking or vaping as risk neutral, there is some evidence that shows this though as well. So as we already showed, there was a systematic review which was leaning toward this way, but another kind of complicating factor in all the previous studies was that the actual prevalence of smokers among COVID-19 patients has been lower than expected, especially given the ACE2 pathway, which is known to maybe bring it into cells. Then you would expect that smokers would be more likely to become COVID-19 patients, but that just isn't being seen. In Italy, they specifically noted that smoking was not associated with their disease severity once people came in and had pneumonia in the hospital. And another study in New York also noted that they had low levels of COVID-19 patients and that it was not related to their hospitalization or critical illness. And lastly, another study also showed that smokers were underrepresented and gave some potential reasons for that. It could be that smoking status is just underreported right now because of the crisis situation happening in a lot of hospitals. They are not collecting information on smoking status, don't have that information available. And if somebody is ventilated, obviously you can't ask them those types of questions. So it it can be quite unclear what the smoking status of somebody is, and getting it reported is difficult during these times. Additionally, something interesting to note, though, is that they also said that this is not a protective factor against COVID-19. There was no evidence of that. So this is really neutral. There's nothing saying that it makes it worse, but nothing saying that makes it better either. The last theory is that nicotine is a protective factor, and this has come out really recently. Due to the underrepresentation of COVID-19 patients who are smokers, that has led some to believe that there is a positive effect of smoking that goes along with infection of COVID-19. Studies from France support this idea and really have been shown as the kind of studies that demonstrate this link. Something to note about those is that they're on an open access website and they have not been peer reviewed and they're not in a journal. So all of this information must be taken with a grain of salt. There have been some possible pathways which have been theorized based on this nicotine is protective idea, though. The idea which has been formalized into theory is that the virus gets into your body and you can either have an adequate immune response, which leads to mild disease and then a resolution, or you could have an inadequate immune response. And that would cause your body basically to overreact and create a cytokine storm, which cytokines are proteins which are created by immune cells and could potentially damage your body if there's too many of them. So an over-response of the immune system could be the problem. And how nicotine plays into this is that it might attach to those receptors and stop the overreaction from happening. So for the same reasons that nicotine might play a role in reducing your body's immune response and weakening it, it may also protect you from over-response is kind of the theory behind this. It's just a theory, though. There is no evidence behind this, and there are just scientists saying that this could be a possible pathway. They know these pathways exist, but this is a pathway that comes after the ACE2 pathway. So that is how they're, this is more when the disease is progressing. Another interesting thing to note about the nicotine theory is that it's not new. A similar theory about nicotine was circulated back in 2003 when the SARS outbreak in China was happening. From Choi et al., they created this paper which was then taken and kind of misrepresented. So they found that smokers were underrepresented for what you would expect among SARS patients, and that none of the healthcare workers smoked, but also were more likely to get the disease. So the convoluted logic goes that because healthcare workers did not smoke but were more likely to get the disease, then it must be smoking that protected the general population from getting the disease. Well, of course, this is not what Choi et al. Said. That's how it was taken in the media, and stories were reporting that it was a smoking cure and you could avoid SARS by smoking or using nicotine. A later case study found that there is no evidence that smoking played any protective role in developing SARS. So we may be seeing a similar situation here where initial evidence is unclear and being misreported, and then we later find that there's no relationship. So it's important to keep this kind of idea in mind, especially as it has spread before. Of course, misinformation is not something we are unaccustomed to right now. Majmudar et al. Found that unsubstantiated claims about vaping and smoking have been circulating on Twitter, specifically vaping though. There's been claims that vaping is beneficial because it increases the humidity, which causes the disease to not be able to infect you, that the devices could act as a delivery vehicle for organic oregano oil, which has been kind of touted as a cure or prevention to cleanse your lungs. And then there's also other components such as polyglycerin, which are essential to vaping products that have been said to cleanse your body as well. So these are all things that are floating around on Twitter and on social media, but also there's claims that vaping increases risks. And as we've seen, that's not known yet either. So there's a lot of information out there and a lot of misinformation happening. So that's important to keep track of. The picture I have here is of one of the quote unquote studies that has been shared. I got this screenshot off of Instagram, and this original study, for lack of a better word, was from a kind of holistic care website that was originally posted in 2003 when SARS originally started again. We're going back to the previous SARS epidemic, and there's no scientific evidence behind this. It's just a kind of something that's been posted on the internet and has been circulated around. But people are taking hold of this and also recommending to other people how to use vapor products with oils like these. So while this is all happening and all this press is occurring, the tobacco industry is responding to COVID-19 as well. There have been calls made for the tobacco companies to stop production. Many say that they have a moral reason to do so. And of course, the tobacco industry is not doing that. They're not taking that action. Instead, they may actually profit from the pandemic. Right now, British American Tobacco is developing a vaccine using tobacco leaves and their own proprietary genetic technology. They told the UK government and the press that they could have 3 million vaccine doses available by June if the UK government would allow them to do so. And so there's no movement on this yet. It's unclear whether countries will take up the offers of British American Tobacco or maybe other tobacco industry companies who might be trying to create vaccines, but it's definitely something to keep an eye on. As related to sales, though, stockpiling and the panic of everybody going to the stores and trying to buy everything led to a spike in sales of tobacco products initially. So there has been concerns that that initial spike has kind of taken away some of the progress because tobacco sales were steadily declining and then there was a spike. And this is concerning, of course, because there are other estimates that show sales have not decreased during the pandemic, and a lot of the tobacco companies are projected to meet their sales goals despite COVID-19. Public relations are also an area, of course, that the tobacco industry is trying to improve right now. One of the things that has been done is in Greece, one tobacco company donated ventilators to a hospital that was struggling with COVID-19. They, of course, faced a lot of backlash about this obvious, as some said, PR move, but there are other things going on, of course, like the vaccines and other technologies that the tobacco industry can offer that they are and trying to appease the countries. So it's important to kind of think how this interplays with policy and how it may affect policy in the future. Another trend that has been happening is COVID-19 related advertising. While tobacco and vaping industries are both doing something around this, it's particularly important for the vaping industry. This can include, of course, discounts for products, delivery to your home, free protective gear. Some of this protective gear is also medical grade personal protective equipment. So that's an interesting part to note. But also there's a lot of false health claims that are going along with this as well. a lot of overstating the health benefits of vaping that is unknown, but of course this is advertising and marketing, so they're trying to show that they can help their consumers during this time. They've come up with some pretty interesting advertising and marketing strategies during this time. Additionally, the overall industry tactic has appeared to be seeming evidence-based. So they are really relying on the available information right now because the available information is so fragmented and it's unclear if there's any relationship. So that has been something that the vaping industry has focused on to also help promote their products and show that vaping is not problematic during COVID-19. In some more positive news, COVID-19 has also caused a number of people to stop smoking. So there have been, of course, images of people on ventilators and in these horrible conditions. So the threat of infection or ICU care being so prevalent and shown all the time has been a motivator for some. And the excuse me, the disruption in daily routine can also be really helpful for people getting out of their habits. But as we know, that can also represent a challenge if you're at home all the time. Despite this, UK survey found that 2% of smokers had quit during the coronavirus crisis, and a US survey found that approximately 25% of combustible and electronic cigarettes users decreased their use. So there is some evidence that people are quitting during this time, but there's also evidence to the contrary. For example, the US survey of about 1,000 people, actually it was about 300. Anyway, they showed that 30% or so had increased their use of electronic or combustible products. So it can go either way, and it can either be beneficial for people or not. So now that we've gone over sort of the available information, we can focus on what we do not yet know, which clearly is a lot. The big questions remain. Is smoking or vaping related to COVID-19 infection? Is it related to severity or outcomes? It's very unclear right now, especially with those three competing theories, what the results of these questions will be. Here are some examples of the research that we need to actually drill down on these questions, though, and get some results. Of course, more epidemiological studies need to be done, but to do that, we need better diagnostic and antibody testing to know who is actually infected. Because if we don't know who is infected or who has had the disease, then it's impossible to know how smoking status goes along with that. So, of course, the entire country is working on getting more testing, but this is really key to making sure that we know what the actual relationship may be. Additionally, information on smoking and vaping status is not very easy to get right now, and a lot of it is not being recorded just to the nature of the crisis. Smoking status is more readily available. Hardly any studies that I looked at had vaping status of hospitalized patients available. This is just a question that might not be being asked as much. I know that in the last few years, hospitals and primary care have tried to add some questions about this, but it's unclear which hospitals have been and how this is integrated into hospital routine. Additionally, there are some more specific data needs, such as any benefits that smokers or vapers may get if they are symptomatic or if they have the disease, if they quit. It's unsure, of course, with the rest of not knowing the overall relationship, but if there's any benefit, we definitely want to know about that. Additionally, there haven't been any laboratory studies done yet about viral contamination specific to tobacco products. So the possible contamination that could happen through sharing water pipes or vapor products or other tobacco products is unclear and not quantified yet. So that should be done soon. But there are some other big questions related to this pandemic. How will this change usage of tobacco and vaping products? And if usage changes, what will the effects of that be? Of course, we have a lot of concerns about usage patterns changing. There's fears of COVID-19 could drive vapers back to using combustible cigarettes, especially with publication and misinformation about a link between vaping and COVID-19. So that is certainly something to keep an eye on, but also use of tobacco or vapor products increasing during quarantine could also be problematic for health in the future. Along with the misinformation and other studies that are coming out, nicotine use starting because it's a perceived protective factor could also be a problem during this time. It's unclear how influential the studies from France or so on will be, or how that will spread over to the United States, but this could be something that we start seeing, is that people start using nicotine patches or other sources to try to protect themselves. Another issue, of course, is that indoor smoking or vaping is likely to rise while people are at home. And this has clear implications for secondhand and third-hand smoke exposure, which we know is problematic. We know that is harmful to health for not only the person who is utilizing the products, but also youth and adults who are in the vicinity. Besides that, it could also act as a mode of transmission for COVID-19, as COVID-19 can attach to particles and then be spread when exhaled. So while secondhand and third-hand smoke, there is good evidence of that, it could also potentially spread COVID-19 as well. So based on all this evidence that's available and all these different theories, what is being recommended by major health organizations? The World Health Organization messaging has been really focused on the risk caused by just the act of smoking or the act of vaping, the contamination that could be caused by putting your hands to your mouth. And also they're giving some information about how it does not protect from COVID-19, some kind of fighting some of these misinformation that has come about. But these are the main strategies that the WHO is focusing on, and the CDC is along these same lines, focusing on what we know, which is that if you touch your face more, you're more likely to get COVID-19. Additionally, the American Lung Association, American Heart Association, American Cancer Society, and Campaign for Tobacco-Free Kids are all discouraging combustible tobacco use at this time. As it is very unclear what, if any, relationship exists with COVID-19, there are always strong incentives to quit and to encourage quitting. We know that overall it's a health benefit. Another interesting part of this is every organization except for American Heart Association listed is also specifically discouraging vaping. American Heart Association just mentioned that there's not good evidence yet. Campaign for Tobacco-Free Kids also has released a statement specifically to clarify that nicotine is not protective. The rest of the organizations listed have not specifically come out with a comment yet, but that may be because it is so recent and so new that this information has come out. Another factor that was included is that cessation resources should be integral to public health efforts. This came across in some of the literature I was reading on this subject. This is important, especially as the pandemic may increase people's desire to quit and increase quit attempts. So having quit lines available is, of course, key during this time. Increasing availability of telehealth or figuring out how that will work in your area is, of course, important, as people cannot go into physical facilities right now. Additionally, ensuring people have access to the pharmacological sort of cessation options available, as it may be hard to get a prescription right now or meet with your doctor. So making sure that those options are still available if somebody does choose to try to quit during this time. Additionally, there might be special support needed if somebody does have the virus and is a smoker, they may want to quit because of that, and that may require special resources, especially dealing with the emotional effects of being infected. Lastly, of course, we want to keep in mind economically disadvantaged persons during this time because they may be facing additional challenges or additional stressors due to perhaps losing their jobs or losing accessibility to their typical sources. So that ends the sort of formal portion of the presentation. Now I'd like to open it up a bit and hear about your experiences during this time. Here's some sample questions to get you going, thinking about how social distancing is impacting your practice. What do patients and clients want to know? And how has your education strategy changed regarding this? So if anybody has anything they'd like to share about that, I'm unsure. Paul, can we unmute people if they request, or? Perhaps using the chat function.
Nope, I had to scroll up to unmute myself. Yes, so people you can unmute yourself. I believe if you're on the phone, you hit *6 and you can unmute. Or if you hit the little people icon in the upper right-hand corner, find your name, and then you can unmute yourself there. Please just do remute yourself after you're done asking the question. The other option is to type in your question in the chat box, or if you're on the phone and you're not actually on the webinar, if you email me the question at tfm@tobaccofreemichigan.org, I'll be actively checking my email, and I can ask the questions as well. Kara, I do see we have one question in the chat from Lisa that asks about COVID transmission through tobacco products, if Big Tobacco is not reducing or restricting production, and the workers that are making the tobacco products are sick or carriers. Is that a risk factor?
Yeah. I think there was nothing specific that I researched about this, but generally that's obviously a concern as a lot of production facilities are shut down right now. It really depends on where the production facilities are, and I don't have quite a clear idea on that, or where the tobacco leaves are coming from. Different states have different policies in place right now, so it's very unclear if supply chain is even affected.
Karen looks like she wants to say something, so let's.
Yeah.
I'm gonna pass her control for just one moment here, and then we'll get it right back to you, Kara. That is, if I can find where she is.
It looks like I can also make her the presenter. Oh, you got it.
There you go, Karen.
Oh, I'm sorry. I didn't mean to do that.
Did you not want to, Karen?
No, I've got nothing. Sorry. That was a mistake.
Oh, okay. Sorry. Then we'll go right back to Kara.
All right. Lisa, can you unmute yourself to say your suggestion?
Can you hear me?
Yes.
Oh, okay. I was just saying that would be a suggestion for future research, and that would also include like liquid nicotine for vaping products,
Right, of course.
you know, to maybe test products to see if it's showing any COVID-19.
Oh, okay, yeah.
I also wanted to ask if people had heard of this news story. I think it was out in California. There was, I don't know why people were there, if they were homeless or not, but there was some location where people were being sheltered. Kind of looked like they had beds with basically bed sheets in between to separate people. And they were talking about how they were gonna bring alcohol, tobacco, and I forget what the third thing was to people because they couldn't leave to go get them and they didn't have the money, so they were going to spend the money to help people who had these addictions to get with, oh, marijuana was the third thing. And I thought to myself, they didn't even mention, well, why not get them like nicotine replacement products instead, or, you know, resources to help them to quit. That wasn't even mentioned in that news story. So I don't know how much that might be happening around the country, and that is something I'd be really curious to find out after this pandemic reduces. So
Yeah, that's an interesting point, especially because it's not clear how well people know about nicotine replacement products or what options are available. So that might also be important to know during this crisis. Additionally, I noticed that somebody asked if these slides will be available. Yes, slides will be available. Additionally, I have a survey that people can fill out if they want to provide their input on these issues due to there being a lot of people and it difficult to share over a meeting like this.
And I'll send out links to all of those after the webinar has concluded. So as long as you filled out the registration form and I have your email, you'll get the link. And that'll just be a plug that if you have not filled out the registration form, please do so that you can get that information. Any other questions?
Yeah, I'm happy to answer anything.
Okay. Hearing none, this sounds like a good break to use the restroom, grab a bite to eat. Jared will be on in about 5 to 10 minutes, and we'll get started with what's happening on the legislative side. Thank you so much, Kara, for this presentation. It was really informative and helpful. It's a very, as I think you made very clear, it's a very unknown situation that there's lots of information coming in from all sides trying to say everything. So having everything be clearly presented, what we do know, what we don't know, is very helpful. So thank you so much for taking the time to do that.
Great, glad to help.
when I went to check, for those of you on the phone, when I went to check my email, I saw a couple messages that people were having trouble getting into this meeting through the webinar. If you had problems, if you want to unmute yourself and ask, we can take these 5 minutes to try to troubleshoot. I'm not sure what the problem is. There's
Paul, I'm having a hard time filling out the registration link. I mean, I have the conference information, but when I type in this HTTPS form to register, I'm getting a error message.
okay, if you wanted, I up in the corner just said talking was, it didn't give a name. If you want to just type your name and address into the chat box, name and email address, I can manually register you. That's easy enough.
Hi, Paul. My name's Dunya Barish. I registered for the conference, but never got the link. I was able to get it from someone else that I knew was registered. I was just wondering if we're going to get some sort of certificate or something at the end if I need to be registered or be able to have that link.
If I need to have your email address in order to do it. If you didn't get a confirmation, maybe something didn't go through with the registration, go ahead and just put your email into the chat box and I will make sure that you get it.
Okay, I'm going to include mine and a staff member as well. She is on the call too, but we both got the link the same way from another person. So I will do that now.
Okay.
Thank you.
There were a couple people that registered as groups. So I had like one registration that came through 3 times with 3 different names associated to it, but only one email address. So that might have been the problem. Or some people's confirmation went to spam.
Hi, this is Joni Detweiler. Mine went to spam, so I recommend people look there.
Okay, and with that, it is now 11 o'clock. Hopefully people are returning to their computers. For those of you that have left, and I am now happy to pass control over to Jared Burkhart, who's the Executive Director for the Michigan Pediatrics Association, and he's one of the leaders of the Keeping My Kids Tobacco Free Coalition, which is a really great coalition that I'm assuming we'll talk about more, that I've really enjoyed working with for the past few months. So with that, thank you so much, Jared, for presenting. I'm going to mute everybody once again, and then I will give you control. Okay.
Okay, so can everybody see my presentation?
It looks good, yep.
All right, great. Well, thanks for letting me come on today and talking with you in this really great conference. I love the fact that even though we can't meet in person, we can still talk about some of these really important ideas and things that we're doing within the legislature and around the state of Michigan. So thank you all for being here. Thank you for inviting me as well. This is really great. So I'm one of the co-chairs of the Keep My Kids Tobacco Free Alliance. It's a group of organizations that came together to really work on starting out with Tobacco 21, but all kinds of other tobacco issues within the state of Michigan. So as you can see, it includes a wide variety of public health organizations, some associations, hospital systems, education groups, just other community groups. We really have a lot of community groups that are really just ingrained in the tobacco-free message and working on this issue with us. I'm one of the co-chairs as well, the Michigan chapter of the American Academy of Pediatrics. The two other co-chairs are Andrew Sheppers from the American Cancer Society Cancer Action Network, and then Jody Radke from the Campaign for Tobacco-Free Kids. So we're doing a lot of great work, and I have to thank my partners as well in co-chairing this. It's a large organization, becoming larger by the day. As you can see, nearly 60 organizations. So they do a lot of great work with me here. And as you can see, here's the list that I pulled down as of yesterday from our website of the groups that are a part of the Alliance. At the end of the slideshow, there is our link to our website. If you'd like your organization to be a part of a member of the group, we would really encourage it. It doesn't cost any money. It's not a money maker, but it really is just groups that are working on tobacco legislation and trying to get smart tobacco regulations in the state of Michigan. So if you don't see your group on here, we would encourage you to be a part of it and join us, sign up. So I think right now I feel like I'm kind of preaching to the choir, but why did we come together? That's a big thing, and we realize that there's a problem. We wouldn't create an alliance if everything was hunky-dory. So we realized that tobacco is the #1 preventable cause of death in Michigan and the United States. The second bullet point really hits my organization home the most. 27.5% of high school students use vapor products, according to the National Youth Tobacco Survey. And, you know, for our pediatricians, they're just seeing it more and more every year. And a lot of people think, okay, well, it's 18-year-olds or 17, 16-year-olds that are going to become 18. It's not really getting down into what we would call like the youth, like really low adolescence. But we're seeing increases in middle school, as many of you probably know. So it's not individuals that are turning 18. They're a couple of years away from turning 18. The more you go into this vape crisis, the farther down the line it's getting. When we're getting into kids before they can drive, 13, 14 years old. And the sooner the tobacco companies know, the sooner they get a kid addicted, the longer that they'll be able to sell them products. And so, our doctors are seeing it every day. And really in this vape situation we're in, kids don't even realize that our doctors are reporting that kids aren't even realizing they're taking in nicotine and taking in tobacco product. I'm talking to adults that say, oh yeah, well, it's just like taking in some kind of steam. No different than if you put a boiling pot of water over your oven, and you'll be able to get that steam into your nostrils. It's the same thing. No, it's not the same thing. There are addictive chemicals in these vape products, and kids don't even realize it. And it's getting to the point where kids even have their own terms. And I know I'm probably, again, preaching to the choir with this group, but kids, the term "nick sick" wasn't a term when I was in middle school and high school, but it's a term now because it's so pervasive in our high schools and in our middle schools, unfortunately. So, it is a problem. We're realizing it's more and more of a problem, and it's killing individuals. They're starting earlier, and we know that if you, again, like I said, if they start earlier, there's a 3 times more likelihood that they're going to be they're going to be addicted by the time they're in their mid-20s with a regular cigarette if they're smoking vape products now. So just wanted you to see some of these stats, but they're the reasons why we came together as a group. Some more reasons that we need to come together. So the first slide was really the overall problems and what are the Michigan specific problems. Well, we're only one of 10 states that don't currently require tobacco or e-cigarette retailers to have a license. We require the 7-Eleven on the corner to have a license to sell beer. We require all the marijuana shops to have a license to sell those addictive chemicals, but we don't require tobacco shops to have a license to sell those kinds of chemicals. And so we're one of only 10 states. We need that to change. And we're seeing this problem within our health systems. $4.5 billion isn't a small amount of money. I think if you talk to any one of our legislators right now, they'd love to have another $4.5 billion, especially in the COVID time, to spend on healthcare costs. But instead, we're having those costs go to cancer and other kind of issues, health issues that are attributable to smoking. So I think that it's definitely something that's not only hitting the health of our population in Michigan, it's hitting our back pockets as well. So we see all these problems and we say we need to get an alliance together. We need to form a group that is able to really advocate for the citizens and the public health of the state of Michigan. So as many of you remember, and I think we're really starting to understand what executives' orders are now under the health crisis. In past times, we'd almost have to really explain what an executive order or a public health emergency actually is, but I think we're starting to realize what a public health emergency is. This one was not an executive order, but it was a finding of an emergency by Dr. Khaldun, who I think we all are starting to understand who she is in all of the 3 p.m. Press conferences that we've been seeing. But September 2019, there was a public health emergency, as many of you I'm sure will remember. And then after that, that public health emergency turned into the governor banning flavored vaping products. So there was a large fight with that for a period of a few days. They took all the flavor products off of the store shelves, and the governor was sued by a vape shop from the Upper Peninsula, saying that they needed to be able to sell this, and actually arguing that there wasn't a public health crisis. Their arguments revolve a lot around the fact that they believe that vaping is a safe alternative to regular physical tobacco and cigarettes. We're going to be able to see through a lot of white papers and a lot of research that it is not a safe alternative, but that's the argument that they're making. And so the court has held it up. They said that in the court's opinion right away, the emergency wasn't enough of an emergency, basically, and they continue to litigate this in court of whether or not there should have been a flavored vaping ban. The bigger problem with this as well is the emergency rules are only for 6 months, and then it can be extended for another 6 months. And basically, as the wheels of justice are turning so slow, it's running out the time clock on this. And we've asked the lawyers, the Alliance has its own lawyers that are working on this for us. And the lawyers say it's a legal argument that the clock is still running, even though this order, it can't be upheld right now. And so, I mean, that's really concerning to us. And we'd like to see this move a little faster. And unfortunately, because of the COVID outbreak, I don't see this moving any faster anytime soon. So what we're working on now really revolves around permanent rules and what those rules could be like for the long term. The state of Michigan, why does the state of Michigan need rules as well? Especially because we've seen some action in some spaces from the federal government, but we really need to be able to have our own rules within the state of Michigan for a few reasons. But one, to make it clear that this is the law within the state of Michigan, and it really makes it clear for local health departments, local law enforcement to be able to uphold these laws when they have conflicting guidance coming to local areas. they really don't know how best to uphold the law. And so the state of Michigan really needs to make it clear that these flavored vaping products should be banned within stores. It shouldn't just be whatever the winds of the federal government decide, but it really should be a vaping. There is a vaping epidemic within the state of Michigan, and those laws should be upheld within the state of Michigan. So we're working through that. We're working through the emergency or the permanent rules, and not working to make sure the emergency rules are upheld as soon as possible. But because there are some things that we can't just do within the governors, with a stroke of the governor's pen, I'll say, there are a lot of legislative changes needed. And we realize that the Youth Tobacco Act had stated in the past, and does currently state right now, that that tobacco shouldn't be sold to or can be sold to people over the age 18. Outside of what the federal government has done, we still have that rule in the books. And so again, like I was talking about a little earlier, there's confusion from local law enforcement and those that are upholding these laws of what can they actually do to enforce some of the federal laws if the state laws are just different. And so we need to make sure that Michigan state law is similar to the federal law. And if the feds decide that they're going to pull back on what they've decided around Tobacco 21, we still need to have a Tobacco 21 law in the state of Michigan. And this is our opportunity. So we started talking to members of the House of Representatives. There was actually a bill in the House of Representatives prior to us forming that would create Tobacco 21 in the state of Michigan by Representative Tommy Braun. He's from the Kent County area. We've been working with him to be able to move something within the House of Representatives and get some good language around that. But unfortunately as well, there were some issues in the Senate. So we had to make the argument to senators as well. So what we really had to do is start with why. And I don't know if any of you read the book by Simon Sinek, but it's a really good book about why do we need to do things. And we've gone over the how, the what's, and the hows will come. But when you're talking to legislators and you're advocating, you really have to start with why this is best. And you've got to realize when there's 110 members of the House of Representatives, not every one of them are going to have the same whys. And so you've got to come up with different whys. Some whys are going to be, we've just got to protect kids from vape products. We've got to protect kids from all of the harmful effects of smoking. And some of the whys are going to be pocketbook questions. It's going to be, if you are not spending tax dollars enforcing this 21-year-old standard, then you're going to spend tax dollars on the public health side, because more people are going to end up with cancer. More people are going to end up with coronary issues, and they're going to end up in our emergency rooms, and we're going to have to pay for it. Those whys are different, and we've got to be able to have those kinds of answers for each individual representative and senator. So we came up with some of our lists of whys. And the first one really is because having a Michigan Tobacco 21 law is critical to make sure that we have enforcement from the federal side as well. It's that same compliance is necessary to make sure that we get our full SAMHSA funding. Within the Tobacco 21 side from the federal side, there is a ramp up period, but we can lose a large percentage of our SAMHSA funding in the state of Michigan if we don't have this law. And so again, it goes back to some of the fiscal hawks that say, well, I think that we should be able to just allow everybody over the age 18 to have their independent choice, which is what they ran on really. But we need to make sure that we get all of the funding Michigan deserves from the federal government. Another one really does go around the tobacco retail licensing requirements. As I said earlier, Michigan is only one of 10 states that does not have a licensing requirement within our state. As I said, we've got all of these other regulated products, including beer, including marijuana, that you have to have a license to sell these products. And what those licenses really do is they ensure that you are holding up your end of the bargain if you're a retailer. You're not selling to someone under the age of 21 in the cases of beer and marijuana, and hopefully tobacco in the future. And if you do that, you can get your license taken away. And that means that's real discipline on a retailer. It's not just a letter that is sent saying, please don't do that again. So we really need these kinds of policies to make sure that retailers are verifying the age of purchasers, and we're able to enforce that in some way. The next why really is that we have a licensure program. If you look at the Liquor Control Commission, they use those funds of the licensure program to go ahead and create incentives for retailer compliance. They have the mystery shopper programs to make sure that if kids are coming up and asking for a pack of cigarettes, they actually get carded. So we need to have these enforcement mechanisms within the state. Right now, it's coming out of general fund dollars. We can use the licensure program to pay for it. And those that are selling the products will actually be paying for their own enforcement of this. And it's really important to understand as well that this isn't just thinking that every retailer is some sort of, is doing things the wrong way. You know, we approach it with the retailers are for the most part, want to do the right thing. I think people in general want to do the right thing. There are always, though, just a few people that do the wrong thing for their own purposes, and they paint an entire section of a community with a bad brush. You know, if someone is playing by the rules and only selling to those that are 21 and older, they should be rewarded for that. And so if right now we're not creating a system that punishes those that are selling to underage minors, and those that are playing by the rules are actually set back in their businesses are set back. They're not able to have a fair competition because there's an unfair playing field. That's part of the government's role, is to really make sure that we're doing compliance checks and making sure that all industries, all retailers are following the rules. So there's some whys there that we're really trying to hit with legislators and make sure they understand that this is a bigger problem than just a public health issue. So what are our legislative priorities as a group? As I said, we've went over the tobacco retail licensing a lot already in this, but we need to make sure that we have tobacco retail license program that includes all, and that all is underlined, all tobacco products, and it's underlined for a reason, because the state of Michigan has in the past really put tobacco products in one bucket and vapor products in one bucket. And as we all know, our doctors at the pediatric, our pediatricians in the American Academy of Pediatrics really see this as a nicotine problem. It's a nicotine problem for public health. And so by using the word tobacco, some legislators are able to say, well, these vapor products, it's synthetic nicotine, it's not a tobacco product. Well, from the public health standpoint, it's a nicotine product. And so what we should say by tobacco is nicotine. So all tobacco products should include anything with nicotine in it, including the synthetic nicotine. So that's really why that all is underlined, because we're getting lost in semantics every once in a while. But again, here are our legislative priorities with the licensing. You can see 1 in 10 states that doesn't have retail licensing. The minimum legal sales age laws have to have the enforcement to work, as I was saying before. And we don't have those kinds of enforcement activities. We looked back on what the enforcement activities have been around the state of Michigan. There are some areas of the state that there has been no enforcement in some counties for over 2 years. That to me is astounding. When we look at a county and that there's no enforcement for over 2 years, that that's gotten out. And they know that there's the ability to sell to minors, and that's really disheartening when you've got certain areas that want to play by the rules, and if we don't have the resources to go do that kind of enforcement, we need to create a mechanism to get the money to do that enforcement, and that's what retail licensing will do. Our next one are the penalties for selling underage, and so like I said before, there are many retailers that are trying to do the right thing. And if we don't have a correct enforcement mechanism, and if we don't have a correct penalty mechanism for fines and suspensions for retailers that sell to individuals that are underage, we don't have a system that works. And so that's why one of our legislative priorities really is making sure that we have a system that works for this. We have to make sure that the burden of selling to underage people falls on the retailer. In the past, it fell on the retailer. It's fallen on maybe the clerk who sold that, but not the person that owns the store. And it's fallen a lot on the individuals who are buying the product. You know, we still have to have some penalties for those people that own stores, those retailers that are selling these products. And so we have the more we put fines and penalties on the retailer, the more they're going to make sure their staff is trained correctly, and they're going to get the kind of point of sale terminal software that they need to make sure that the individuals that are actually buying this product are of age. And so a big part of every single state that's doing this right, a big part of it is making sure the retailer penalties are done correctly. And that's why it's one of our legislative priorities. The next one is our enhanced enforcement around these products. Again, I feel like I'm bringing this up again and again, but it is an issue. If you don't have enforcement, then nobody's going to play by the rules. It's the reason why we have police out on the road to enforce the speed limits. We need to have enforcement around tobacco in the state of Michigan, and currently it's not being done in an adequate amount. And as you can see, the 2019 FDA compliance rate, the retailer violation rate is 19%. That is astounding when you think that the next highest state was Florida, and that was around 10 to 12%. So we are just insanely higher than every other state in the United States. And a lot of it has to do with the fact that there is an enforcement. So this is an enforcement we know. I think it's astounding to me, and I hope it is to you, that individuals in Dearborn sold to kids 41% of the time. That's not, it doesn't matter what we say as far as tobacco 21. If you're still selling to kids, we could make the legal limit for tobacco 60. If you're selling to kids almost half the time, there's still going to be a public health epidemic. And so this is one of our priorities that we're really pushing, is to make sure that there's enforcement when the rules are on the books. And we also want to repeal the PUP laws, and the PUP is purchase, use, and possession. Again, it's that kid that's going up to the counter and asking for cigarettes or vape products. You know, what we've done it backwards in Michigan. We're really trying to penalize a kid. And I know in some cities they put a $500 penalty. I don't know a lot of 16-year-olds that just have $500 that they can pay a fine with. That brings mom and dad into the equation. Well, and what does it do to stop the next kid from coming and trying to buy some kind of vapor product? We really need to make sure that we're stopping it at the point of sale, we're stopping it at the retailer, but not going after 16-year-old kids for being 16-year-old kids. And it hasn't been shown to be effective. If they were effective, we wouldn't have the kind of public health crisis we have today. So what we are asking for is totally removing the PUP laws. We understand that some legislators still want to have some kind of penalty just to make sure that there is something to keep kids from buying it and they don't get a free pass. You know, we're willing to have that conversation, but $500 penalty just seems way too high, that I know some local jurisdictions are putting in. We need to have something that's smarter about making sure that we're not giving kids a record at 16, and we're really making sure that we're stopping it at the point of sale. So those are our big priorities legislatively. Next, I'm turning to some of the active legislation that we have. So as we were talking to members of the House of Representatives, there were a set of bills. Now you can see the 5 bills right there that were introduced in the Senate. So we had to quickly change our strategy in getting a tobacco 21 legislative fix out of the House of Representatives. We had to shift gears to this group of 5 bills that were introduced and getting a quick hearing in the Senate. And if anybody works downtown Lansing and sees a bill introduced, and then they see that there's a legislative hearing within a week or two, you know that it's on the fast track. There are a lot of bills that never get a hearing. And so for bills to get a hearing right away, it means that there's something behind it. Well, we sat down with all of the individuals that introduced the bills within a week or two, in a couple of cases, of introducing the bills. And what we found out quickly was that these were bills that were given to these members by the tobacco industry. They saw a situation where, there was a tobacco 21 federally, and they could change our laws to do things that made it look good for individuals or senators to change the purchase age to 21, but not really change the environment that would help public health. And so, like I said before, they're fine with changing the age to 21. They could change it to 60 if they're still selling to kids, they're still selling to minors. And they wanted to make sure that, in my humble opinion, they wanted to make sure that they could still keep their businesses going and operating, and make sure that they're getting kids addicted before 18, before 21. And so we read through all of these bills, and there were a lot of holes. I think in talking to all of the legislators, a lot of them had some really good intents. They don't want to see kids smoking and vaping, because vape it's a big issue. And so I think a lot of them had a lot of really good intent, but they needed to hear from everybody. And so that's why we set out to make sure that they heard from us, and they saw some of the places where they could make their bills even stronger. So if I can just run through some of these bills right now and where they sit. Currently, we're still working with the members that introduced the bills. They've had 2 hearings within the Regulatory Reform Committee in the Senate, and that's where they're at right now. We heard before the COVID-19 outbreak that they were set to be passed out of the Regulatory Reform Committee, but then COVID hit, and the Reg Reform Committee still has not had a committee hearing. But I expect that once the Senate gets moving again at their normal pace, or whatever their new normal pace will be, I'm sure it will be at the top of the chair's mind to try to get these bills moved on to the full Senate. So Senate Bill 781, introduced by Senator Ananick, would increase the tax rate on tobacco and vapor products. And yes, we need to make sure that there is a tax rate on vapor products, but these taxes, we know, will keep some kids away from buying these products. The problem with the way these bills were set up initially was that the tax rate for the vapor products was less than cigarettes. And in some cases, we have different rates for cigarettes, we have different rates for cigars, we have different rates for OTP, other tobacco products, and now we would have different rates for vapor products as well. This really is a quality issue that we need to make sure that if you're buying a tobacco product, there's the same tobacco rate. And we need to be able to use that tax to be able to enforce we need to be able to enforce all of our tobacco retailing industry to make sure that they're not selling to kids. And so what we're pushing for is to make sure that every single tobacco product, whether it is a regular physical cigarette, a cigar, other tobacco products such as chew and snuff, and vapor products, are all set at the same bar. So we're working with the senator to try to find a solution on that, but there are things that we're certainly advocating for in that bill. Senator Bullock's bill started to create the licensing system for vapor retailers, but interestingly enough, it was for vapor retailers only and not tobacco retailers. And so we know that when a lot of these vapor retailers are housed within a tobacco retail shop, and so if you go into Wild Bill's tobacco, they could be selling vape products, they could be selling cigarettes, they could be selling loose leaf tobacco, all of these other tobacco items, and it really should really be all encompassing on one license system. If we look at when you go into a party store, we don't say that, well, beer is under this license, but those new seltzer waters are under this license, and then here's another kind of flavored alcohol product. It's all a one license as far as beer is concerned. Tobacco should be the same way. It shouldn't be what type of tobacco you're selling or vapor product. And so, we really, from the AAP standpoint, want to see all nicotine products under one licensing system, and we need to look at what other states are doing to make sure that we're getting the best of every state. We would still, under the bill as it was initially written, have a license system, but it would be far behind what other states are currently doing. So we need to keep that up, and we're working with Senator Bullock to make sure that he has a strong bill that would make sure that all tobacco retailers are licensed, and we're hopefully getting somewhere on that. But I'm just appreciative of the fact that he's still having a conversation and looking to us to try to get some suggestions to him. Senator Tice would increase the age of purchase to age of 21. And so there are some things within that too. I think that sounds good at the beginning, but they took away just took away all of the 18s and changed them to 21s, and so I think that we really need to look through the bills and make sure that we are doing things in a way that really would keep the cigarettes and tobacco products and vapor products out of the hands of those that are underneath the age of 21. As we've known in the past, people under the age of 18 were getting cigarettes, they were getting vape products. So if all that we're doing is changing the 18s to 21s, we're not doing anything on the enforcement side. And that's what we're really looking to do, and hoping that we can work with the senator to make sure that we're keeping these products out of the hands of people under 18 and under 21, so our public health crisis can diminish. The last two bills, Senator Zorn and Senator Wayno's bills, 784 and 785. 784 regulates vending machine sales for vapor products. It is similar to what we've seen for physical cigarettes. The Age Majority Act was also changed to increase the purchase to age 21. I noticed now that I'm looking at this must have been, there's another bill, 786, that's also missing from this slide, so I apologize for that. Senator Runstead actually has a bill that would eliminate some of the marketing to kids. We're looking at that bill. We want to make sure that it is very similar to the marketing issues that we have at the federal level. The last thing we want to do is create a situation where state law and federal law are not mirroring each other, and we have again, law enforcement looking at two different sections of law and saying which one's the one that we need to follow. So we're working with his office to make sure that bill is very similar to what the federal deeming policies already look like. So that's a quick overview of the active legislation that we have going on right now. We're working with the bill sponsors. We're working with other members of the Senate, members of the Senate Regulatory Reform Committee, to make sure that we're establishing policies that keep tobacco out of the hands of kids. And so I guess the question is, how are we doing that? Well, right here, advocacy looks many different ways, but the first thing, we need to get just education into the hands of our lawmakers. So as you can see, we have, on the left, it's a lot of examples of some of the white papers that we've given to lawmakers when we went in and talked to them. We're doing a lot of face-to-face meetings within lawmakers' offices, showing them the white papers around a lot of things, Tobacco 21 and around tobacco. As everyone on this call, I'm assuming, understands, there are a lot of individuals that are peddling some false narratives, including, like I said before, that vape products are safer. There was a paper done out of the UK that said that it was safer than just regular cigarette smoking, physical cigarette smoking, and so that has been just used right and left to say why we need to make sure that we get vape in the hands of, I guess, every adult and every kid in the state, I guess, is their outcome. So we're trying to use white papers that have some scientific backing to them. And then we have our own materials about the dangers of tobaccos and e-cigarettes, and how we need to change the law. And so we're handing these out to legislators. We're making sure that they have them. They have the information that they need to make the right decisions. We're also showing up to committees. As you can see, we put together, these are just members of the coalition that were able to testify on one day, or over a couple of days. We're bringing more and more individuals in. There's a picture of a group of high school kids. I didn't want to take that picture, but there's a picture of a group of high school kids that we brought in from Southeast Michigan as well to speak to the Senate Regulatory Reform Committee. And it's really powerful when you can get kids that are still in high school to talk about the issues that they're facing. When doctors are always very powerful, and advocates that do this professionally are very powerful. But when you can get somebody that's sitting in their science class saying, I know the kid next to me is vaping, they're taking bathroom breaks in the middle of class and using the bathroom as their vape room. All of those kinds of personal stories are just powerful. And so we were able to have them in front of the committee. We were also able to have some doctors talk about, their experiences in seeing kids and some of the stories that they've heard from kids. One of the doctors that I've talked to had talked about how a young woman who was just out of high school, under the age of 21, was having a child, and her two friends came to congratulate her at the hospital. While she was in the delivery room, they were vaping with some kind of fruity smelling vape product to make her hospital room smell like fruit and tutti frutti. That's the last place that our pediatricians want to have a brand new hours old born baby child. And so that just goes to the knowledge that people have about what vaping actually is. The marketing side of the vape products are so persuasive that it should be everybody's breakfast cereal at one time. And I guess I'm a little bit of my editorial there, but they really get some kids to think that this is safe. This is no different than going outside on a rainy day and breathing in water. And it can have long-lasting effects on adults, and especially kids who are hours old. And so we really need to get those stories out to lawmakers to help them understand how this problem exists in society. So those are the things that we're working on right now. We're right in the middle of an advocacy effort. As I said, the Regulatory Reform Committee is chomping at the bit to try to move some T21 bills, and we're working as hard as we can to make sure that they do the best they can. We're given the best public policy for public health in the state of Michigan. I'd like to say I'm really proud to be a part of this group. I've worked in a lot of coalitions in Lansing, but this group has come together, and it really feels like the group is working really well and wearing the white hat to make sure that kids are protected in our state. And there's no better feeling when you're able to get something done. And this group has also got a lot done in a very short amount of time. All of the facts are on our side. We just got to get out there and educate lawmakers, and I think we're doing a really good job. Again, that I'm biased in that, but I really feel like we're moving from a package of bills that the vaping industry was promoting and pushing as fast as possible to a package of bills that really protects kids' health. So I kind of went through that, and I wanted to open it up and see if there is any questions about the Alliance or anything that I can maybe talk about for you guys.
Yeah, thank you, Jared. So there were a couple questions in the chat as you were going through, and we can just run through those. I think these are pretty quick answers. Kelly asks if with the changes, do most of the penalties on still get excuse me. Do clerks still bear most of the weight if a retailer gets caught selling?
So we have provided drafts to legislators that what we would think that is the best policy for the state of Michigan. In our drafts, the clerks don't bear most of the weight. They bear very little weight. Actually, our preferred policy is that, excuse me on that, our preferred policy is that clerks really don't bear any weight, but there are some legislators, some senators that are saying that they know of store clerks that's how they make a little bit of money. I'll sell you this, you give me $20 and I'll sell it to you, and they might get fired from one job and they'll just go down to the tobacco store down the street. And so they really wanted to have some penalty on the clerks, but as we're having these conversations, I strongly feel that the clerks are going to receive some sort of small civil penalty, but nothing huge at all, not like we've seen in the past.
Barry also has a question, and this was one of the things that really jumped out at me when I was reading these bills for the first time. What is the cost for a business to be licensed, and could this be a barrier to policymakers supporting the bill?
Yeah, no, that's a great question too. In digging in the first set of bills, it's really funny. The license fee was $25, and I almost fell out of my chair when I read it. In my mind, the cost to be able to sell these products for an entire year, I said it to a couple of legislators in meetings. The cost of a retail license to sell a carton of cigarettes shouldn't be less than a carton of cigarettes. And that's where they started out. What we're pushing for in our research around the country, $100 doesn't seem unreasonable. We'd like to see it even higher than that. Some liquor licenses can get up to over $1,000, but around the country, if you want to compare, if we're in the $100 range, $75 to $100 range, that's probably well in line with many other states. So at the end of the day, I don't think it's so much that a retail establishment wouldn't be able to pay for it. What's more important is they have some skin in the game, and that license can be taken away, because that's where you're hitting them in the wallet. If they're doing something wrong, you're not able to sell tobacco for a week. That's where the real penalty might
lie. And just to note that in the current version of the bills that have received some amendments, those fees have been raised to that $100 level for initial, and then $75 for annual renewals. And then we've got Kara, maybe you can clarify this a little bit. Kara asked if you can provide links for the data and where these mandates can be found. I'm not sure which mandates.
Okay, this is Kara. I will give you a little bit of information what I'm asking. I think that the information that he shared earlier with the data for the Detroit and Dearborn areas was under the federal link, if I'm not mistaken, but I wanted to make sure if that's where the numbers and the percentage he was sharing that from. And the mandates he gave at the top was the 2 compliance check mandate. So those were what I was referring to.
So for the 2 compliance check mandate, that's just our priority. And so as we are giving suggestions to legislators, that's what we would like to see in the bills. So that's just kind of our recommendation. And as far as all of the other the links, I'll have to be able to provide those to Paul, and hopefully he can get those out to everybody. We have them on the palm cards that I showed in one of the previous slides that we're handing out to all the legislators. We have footnotes on them. And so I can get those footnotes out to you. I just couldn't include them in my slide deck today.
Thank you.
And Carol, I'm pretty certain that you are correct that that is the federal data that it came from. Sue asked if we can get a copy of your PowerPoint slides, Jared.
Yeah,
you're okay.
I can send those out to you, Paul. If you can get those out to the rest of the group, that'd be great.
That'd be perfect. And then Cliff Douglas from U of M asks, can you clarify again why Michigan should enact its own Tobacco 21 federal law when federal law already mandates a minimum age? Could it pose a conflict in any respect? Could it strengthen Michigan's hand in a specific critical way?
Yeah, again, you know, it would strengthen Michigan's hand just to make sure that law enforcement is clear on what the standard is. We're receiving a lot of feedback to our group that local law enforcement is weary to really enforce the Tobacco 21 standard because they are looking at the laws in the state of Michigan, and the laws in the state of Michigan say 18. In some law enforcement circles, they believe that if it's a federal guideline, then the ATF, or tobacco and firearms, should be the ones coming in and enforcing that federal standard. We're not going to have the ATF come in and do a compliance check on 7-Eleven in the middle of wherever. And so that's the DHHS, and that's local law enforcement, and in many cases too the state police. Well, we need to make sure that there's one standard. And so I know that there are some jurisdictions where the law enforcement is very willing to enforce that standard, but there are some jurisdictions that law enforcement is not willing to enforce that standard. So we need to have that state level policy the same as the federal 21.
Okay. And here's a question that I do not know the answer to. Patty asks, or says that there's great work around teens and vaping on the advocacy side. But is there any advocacy or legislation that you know of talking about exposure to nicotine for infants, prenatal or after birth, as that's a leading contributor to infant mortality?
Yeah, that's a great point. I mean, and from the AAP side of things, that is something that we see on a far too frequent basis. I think that that's not something that this coalition is working on. I know that we're working with the maternal and child infant health group to be talking about issues like that. And so from the AAP standpoint, we are working on issues like that. And working through kind of the budgeting process to get more education out to expectant mothers and new mothers. But as far as the Keep Kids Tobacco Free Alliance, that really hasn't been our primary focus as of late. I think that there will be, as this as the alliance moves forward, there'll be other avenues we can work into, but I know there are other groups such as mine working on that as well.
And is there any legislation or proposed or active that you guys are working on for that?
From a regulatory standpoint, a policy standpoint, I'm unsure of any right now, but I know that there's been a lot of conversations around the budget and what things can be put into the budget to look at that, including the how home visitation stuff has always been that point where a lot of this education can be housed.
Okay. And then Lisa Danto asks, under the new recreational marijuana law passed by Michigan voters, can it be a comparable model for tobacco retailers, or a warning of what needs to be avoided? Comparing to marijuana dispensaries.
Yeah, I think that's that's one of the things that we're looking at. We're really looking at that new marijuana proposal, or not proposal, now law, but as they're building out the marijuana regulatory agency, it's not completely built out. And then also looking at the Liquor Control Commission. as another one of the regulated industries as well. And so, yeah, I want to be able to see something comparable to one of those two organizations. And I think everybody can just see how they have the enforcement side built out really strongly. So yeah, those are the two organizations we're looking at as models in the state of Michigan.
And then Barry asked follow-up comparing to the cost of licensing. He's wondering if there are any other requirements to possess a license.
Right now, I mean, that's something that as this gets built out, the department of Laura, the licensing department, would have to figure out, much like as we just had the conversation around, much like the marijuana regulatory agency, you know, they started out with the law and then they had to create a few rules to make sure that they followed the law. And just kind of the process of how that will be done. Laura would have to develop some of those. But right now, I think we really just need a list of who is licensed, who is selling tobacco products. That way we can start the enforcement. It's really more of a ability to sell, and if you're selling to minors, we take that ability away is the biggest hurdle that we're looking for.
Yeah, I think the only additional requirement is that you not have additional penalties for selling to minors, multiple additional penalties in the previous years. That's specifically spelled out in the legislation, but as you said, generally Laura is the one that will create how you actually go about applying and possessing the license. So that is the end of the questions that people have typed in. If anybody wants to unmute themselves, which apparently you can do by just hitting the little red microphone on the bottom of your screen, and ask a question, or if you are on the phone, I believe hitting *6 will unmute you. And again, if you want to email any questions to me, I would be more than happy to read them off as well. So hearing no additional questions, thank you so much, Jared, for coming in and giving this presentation. There's definitely a lot going on down at the Capitol. I would just want to echo your comments about the Alliance. I've worked with a number of coalitions over the years, and I'm really impressed with how this one is working. I think it's a really strong group of people that are involved with it. I think the organizations are active. There's a real commitment. And as you said, it's a really good good cause. The data's on our side, so we've got strong cases to make. And I've enjoyed working with you guys for the past few months. So with that, I'd like to thank everybody that made this possible, the TFM board, the tobacco section at Michigan Department of Health and Human Services, and all of our members for putting this together and giving us the money that we need to be able to do this. So the morning focused on sort of what's happening out there in terms of research and on the advocacy legislative front. This afternoon is going to be much more focused on what we can do in this environment. So the first panel is one that I'm looking forward to. It's going to be a three-part presentation with Libby Stern from Spectrum Health, Amanda Holm from Henry Ford, and Allison Nix from the University of Michigan, talking about how they're providing services under the new guidelines for social distancing and everything else virus related. And then following up that will be Ashley from American Cancer Society Cancer Action Network, talking about how we can continue to make sure that all the progress that we had gained on the legislative and education front before the coronavirus took over everything doesn't get lost. So with that, we're back up to 100 and almost 140 people. I think we were at 150 before lunch. So I am going to pass it over to Libby to start the presentations. Just find your name and we'll get you there.
There you go. Thank you, Paul. I hope can everybody hear me okay?
Yeah, I can hear you.
Yes.
I can hear you.
Good. Okay. Well, yeah, thank you so much, Paul, for all the work that you've done with this too. I just echo your appreciation to the rest of the board and to the tobacco section and MDHHS and everybody that's here at the conference. I think that's fantastic. And I hope you're able to join next year too. And I hope we'll be in person next year. But anyway, I really appreciate all the interest and the attendance. So as Paul mentioned, I work at Spectrum Health in the Grand Rapids, West Michigan area, really. And I feel like I agree with you, Paul, that I think this is an interesting, very interesting to touch on because it has been a big switch for all of us, I think. And so what I'd like to do is just tell you a little bit about our program and how this COVID-19 crisis has impacted our program, and then also touch a little bit on what the challenges and what the successes have been. So I'll start with saying we really, even though I've been in the tobacco field for a number of years, we launched this program within the lifestyle medicine department not even a year ago. So just in the past year, my role switched and we launched our program and have been working on getting it up and going. We're just kind of in the beginning stages of it, really, but Spectrum Health does have about over 20 tobacco treatment specialists, and they're really scattered throughout the organization, and they're in different departments. Some of them are embedded in programs like surgical optimization or oncology, pulmonology, and then others are in different departments. Many of them have dual roles, so they might be doing several different things. And they're not all in the lifestyle medicine department, but us launching this program has been a good opportunity to kind of connect all those folks, because that was really one of the problems we were dealing with, was that none of our services were connected. There was a lot of siloing and that sort of thing. So this has been a nice opportunity for us to really work together and get more involved with each other and what we're offering. We want to be able to offer to patients and to community members wherever they are in the Spectrum Health system. We'd like to be able to offer them the same thing. So that's been really exciting. So our plan has been approved to include in-person and virtual opportunities. So in-person cessation classes, a support group, one-on-one, and then also virtual one-on-one and digital coaching and resources as well. So that, we were just kind of getting started with a lot of this work. So with the COVID-19 crisis, it took everybody kind of off guard. Certainly, we were very, very busy in the lifestyle medicine department. It's a small department, but a lot of things are going on in that department. So the medical practice is housed in that department, and also culinary medicine program is housed in lifestyle medicine. So a lot of things have been out of classes and just all sorts of work going on. And the COVID-19, once that hit our communities, we were all asked to shift from working with people in person, just like everybody else, to working from home. And so that certainly had some challenges, but lifestyle medicine responded very, very quickly and was able to really flip all the programming from in-person to virtual. So for the tobacco and nicotine treatment program, we have a Quit 101 cessation class and also a support group. And both of those, just within the last couple of weeks, became virtual. We've been providing internal blog posts on our internal website at Spectrum Health around coping during the crisis and the importance of quitting during the crisis. We were able to provide a webinar called No Better Time to Quit, and looking at the risk factors of COVID-19 for people that are smoking and vaping, and also introducing the idea that if you're sheltering in place and staying at home, that can be a good opportunity to quit, as well as introducing some coping strategies, right? Stress management kind of strategies. So we've been offering those. We also have transitioned, really all the TTSs throughout the system have primarily transitioned into providing telephonic support, and then also virtual support through the Spectrum Health Now app that typically is used more with providers in the hospital setting, although I guess some outpatient. I mean, there's really been a increase in that as well with the crisis, but being able to offer those things virtually to people and to reach out that way. And then also we've had social media opportunities with increased exposure through social media, as far as news media and Facebook and LinkedIn and that sort of thing. So we've been able to get the word out about our program, which is really helpful. So within the lifestyle medicine department, I feel like, I really feel like the whole department was ready. Some more ready than others, probably. But, we were very ready and willing to make this switch over to becoming virtual, recognizing how important it is to still be able to reach out to the patients and reach out to community members and be able to offer that support. So I do feel like our department was ready. And also, I think we've had a lot of support from our internal communications team in terms of, I touched on that a little bit, as far as getting things out on Facebook, getting things out on LinkedIn, and really making people aware of what the opportunities are. And I have an example of that with the Quit 101 class. At the time that we had to start working from home, I was in the middle of a Quit 101 class, which is a 4-week cessation class. And we had just finished the second week, and at the end of that week, we all were starting to work from home. And so as I with that, made an effort to reach out to people and connect with people and try to finish that class up virtually. And what I found was that, a couple of the people that were in the class were very willing to do that, and others, and I think Kara touched on this earlier this morning, in her presentation. Some of the others were really just kind of paralyzed by this whole thing. I mean, they were really struggling with other things that their smoking was really not something that they were prepared to deal with at the moment. So, but with all the media exposure, the next Quit 101 class that I started virtually, which was just last week, really reached a lot of people. And we had people sign up from a variety of different states: Connecticut, California, Massachusetts, Wisconsin, I think. So it really, in some respects, I mean, I feel like it's helped because it has reached more people, and it's available, easily available to folks, where sometimes in person is not so much. We at Spectrum Health use the Microsoft Teams platform, which our information systems team supports. So we've been using that for these classes. And although there have been some, I would say I definitely experienced some kinks early on, I feel like it's working out. Or I don't know if it's it or if it's me, probably me, right? But I feel like we are able to reach people fairly well that way. And the folks that I've been working with have been receptive to it. So I appreciate that as well. And then, as I mentioned, Spectrum Health Now platform is available. I feel like this has given us an opportunity to kind of revisit things and make them better suited for a virtual presentation, because a lot of the in-person stuff doesn't necessarily transfer, I don't think. So that's been a good opportunity. And then I feel like our work is really supported by Spectrum Health's priorities and mission. So, you know, saving lives, reaching our patients, reaching out to our patients, providing what our communities need. Those are part of the mission and vision. And I really think that being able to switch over to virtual has helped with that. And then I guess lastly, as far as challenges, I think some of the regional spaces, Spectrum Health has, I believe, 14 different hospitals. So some are out in more rural communities and spaces where there are some limitations in terms of patient and community access, and also in terms of what the TTS perhaps has available to them. So I think that's been a bit of a challenge, but I feel really strongly that our regional folks are making that transition as well, and figuring it out how it's going to work for them. We've also had some of our TTSs who have been redeployed into different roles, a couple of layoffs. Spectrum Health hasn't had a lot of layoffs, but some physicians have been laid off. So that's a challenge as well. But even the redeployment, put into a different role or different situation, a different setting, has had an impact. And then I think too, the learning curve, just kind of, and I touched on that a little bit ago, but I feel like just being able to really successfully manage all of the electronic and virtual and telephonic and all of that stuff has been a challenge, but it's also really an accomplishment, I think, to get on the other side of that. So that's really basically what we've experienced. And like I say, I do feel like I'm excited that we've been so successful and we've really been able to flip things very quickly, I feel like. And yeah, it's exciting. It's a whole different approach, but it's working. So yeah, so if anybody has any questions or anything specific for me, I'm happy to answer them now, or I don't know if we're going to do that at the end, maybe, Paul.
I'm open to either one. I thought we were going to do them all, but we can do questions
okay.
now if people have
That's
questions
fine.
for you. Okay.
Well, yeah, that's fine. Thank you.
And who is next, Amanda or Allison?
Allison, I think.
Okay. In that case, Allison, you are now the presenter.
I think I'm doing this right. Can everybody hear me?
We can, and it looks perfect.
Great. Okay, thank you. Well, thank you, everyone. Thanks for Paul for having put this panel together so we can talk a little bit about how we all transitioned in a really sort of challenging and really different time for all of us. So I wanted to just go through some of the shifts that we've made at the Tobacco Consultation Service at the University of Michigan. And I wanted to start talking a little bit about what we had to do, and Libby talked about this, like shifting our work environment. And so one of the things we had to do was really quickly set up remote work environments. And so lots of thought about like how we would set up our spaces at home. And we were really lucky that about 18 months ago, we all got laptops, which made it really helpful. With the exception of one staff person, we had laptops that could go out to people's homes and we could, you know, start using them. Thinking about like docking stations and monitors, we set up remote faxing, things that had to happen pretty quickly to kind of to mimic our office structure and the workflow that we have typically in person. So that was one thing. And then also, you know, how are we going to connect? You know, the university typically uses Blue Jeans, which I don't know if people are familiar with that, but then, you know, people started talking about Zoom, and we also have Skype. And so, you know, in a week's time, you know, what could we use, because we were going to start seeing clients, you know, and talking to patients on the phone or, you know, possibly through video, you know, were those systems HIPAA compliant? You know, were we able to share patient information with each other, you know, during meetings, et cetera? So, you know, that had to be identified and get up and running quickly. You know, and as a manager, thinking about like, how am I going to connect with my people now? You know, and how are we going to connect to the greater department? And what is that going to look like? And so pretty quickly decided that it was going to be really important that we met and talked once a week. With me one-on-one with my team. And it actually has proven to be really, really beneficial, and something that I was like, are we going to be able to have stuff to talk about, you know, once a week? And we really do. And they're full, they're 45 minutes. And I mean, there's just so much going on right now that talking about work is one thing, but also just connecting and listening and being supportive. And so that's been really, I'm glad that happened quickly and that we were able to set those up. And then also semi-weekly meetings with our leadership. So our senior director meets with us twice a week, and the whole department, I'm Healthy, to talk about things that she's hearing that we don't hear typically, and also sort of deciphering and interpreting some of the messaging we're getting from our president of both the university and the hospital. And then just from like a personal perspective, there's a group of individuals who have set up like coffee chats with colleagues so that they can be a little bit more informal and just really connecting and supporting each other through this really, really challenging and different time. And then the other thing I think was important is to really sort of think about, you know, what does support look like for your team? What does that feel like for them? What is important to them? I thought, you know, being really transparent, which is a message and that comes from our upper leadership, you know, is really sharing what we know, you know, not being, you know, scary, of course, but really just being like honest, like, you know, we don't really know what's going on right now. And as soon as we do, we'll let you know. Understanding, empathy, communication, the space to give people to do their work. It's a lot different to manage people from a virtual perspective. So just allowing people to kind of figure out what works for them, and giving them the space to be able to do that. So now I'll shift to talking about, shifts in our service delivery. So we have outpatient services as well as inpatient services. So I'll talk about outpatient first. Like Libby talked about, we had to make a quick shift from pretty much mostly all in-person appointments and client sessions to the phone. And so, what phone were we going to use, and should we call from our phone number, and setting up ways to sort of be protective of our information, but also be able to have easy access to being able to do sessions from home. We have started doing video sessions. We are using Zoom, and we've just started doing that in the last couple weeks, and that's actually proving to be pretty interesting. I think I work with employees at the university, and I think that they like that they're sort of used to that system, and they're used to that way of communicating. And so this is just another extension of that for them. And so I have found that to be really helpful. We had to create workflows and system changes to support video sessions. So, how are we categorizing our sessions or our client sessions in our database, and who's setting up those appointments? How are we doing that? Do they have access to be able to do that? So not was it just a click of doing that, but it was sort of also thinking about workflows and system changes to support us being able to do that. Almost all of our hard copy mailings now are sent via email. We're lucky that we're in an age of technology where most people have email or have a way of accessing email either through their smartphone or a laptop. So we've done a pretty big shift on, and it's a good thing. It's a good thing to be doing that, not only because there's a pandemic, but also just from an environmental perspective. We have found that we're probably doing, I think our sessions are a little bit shorter via phone, more frequent. I think our clients we're finding are needing a little bit more support and more frequently. And a lot of more discussion of obviously about mental health and coping and sort of how we can support individuals in a professional, using good professional boundaries, but also understanding that this is such a different time for individuals that we really need to be cognizant of how that's affecting their ability to change their behavior. And then student sessions, interestingly enough, we do see University of Michigan students. Not very many are around in Ann Arbor right now, but when we were seeing them just a few weeks ago, I was experiencing that they were wanting to talk more, have more socialization. They were much more isolated. And really, particularly, I have one client who was like, I'm not really talking to anyone. My roommate's never home, and I just don't really have a lot of contact with people as people were leaving Ann Arbor and graduating. So really spending more time with the students. And then just anecdotally, we're finding that our conversion rate from referral to treatment has been a lot higher. And although the numbers of individuals being referred to our program have gone down because we're not doing elective surgeries right now, so there's a lot less physician referrals, those individuals who are coming to us are entering the program. And they're expressing fear and concern about COVID and its impact on, if they got it and if they're smoking, what does that look like for them? And so we're seeing that many people are making big commitments right now to trying to quit. So on the inpatient side, we do bedside assessments in person at our hospital, and we've seen a significant reduction in patient numbers, mainly due to limitations in admissions because we're trying to keep beds free, or we're trying to keep beds free for COVID patients. And so just like our outpatient services, we've had to make this shift from bedside assessments to phone assessments. And it can be pretty challenging just on a regular day to reach people via phone if there are times where we can't get over to the hospital. But we're finding that the individuals who are ending up being admitted are very sick, probably the sickest of the sick, and they are needing, maybe phone isn't the best way to get through to individuals. And so this has been, I would say, a challenge for our inpatient team. And so in sort of response to that, we have in the last few weeks created a new workflow where we're reaching out to patients who actually have been discharged and have been home. We use Epic, and I know some of the other health systems do as well. We've been able to work with Epic to create a discharge list for us so that we can give people a couple days to get home, get settled, and then we're calling them and saying, hey, while you were in the hospital, you know, we noticed in your history that you're a current tobacco user, and then having an assessment and an intervention once they're home. And so we've just started doing that, and so hopefully we'll have more information to report on how that has worked. That also created the need for new documentation and a new note in our MyChart system. And so we're hoping that although our numbers have gone down for admitted patients, that we'll be able to reach people once they're discharged. And then in addition, more opportunities for skills training. I find that this is something that often falls off, you know, the radar when you get busy and people are, you know, their time and energy is focused on the patients and the clinical work. And, you know, skills training is always important to make sure we're staying up on our education, we're staying up on our motivational interviewing skills. And so we have this ability to have a little bit more time to be able to devote to training our staff. And then finally, just future shifts to consider. You know, some of you may know that University of Michigan just put out a voluntary furlough and an invitation to individuals to reduce their hours. And so we do have some of that impacting our team. We have someone who is going to furlough and a few people who will be reducing their hours. And so, like, what does that look like when that shifts the workload to other individuals on your team? And you know, we just don't really have a sense of, you know, what the future holds. And so this can be a little bit of an unknown and again, another challenge for our team. The other thing that we're thinking about too is different messaging to the community and patients. And so we've worked with our communications team to put together supplemental resources on our website so that individuals who are interested in understanding COVID and its impact on tobacco users, there's some more information presented to them that they can find on our website that we obviously never had before. Our tobacco treatment specialists are talking about how, you know, I said before, patients who have mental health issues are, you know, these things are escalated because of this time and the unknown. And so really checking in with patients, not only about their tobacco use and how that's going, but, you know, is there anything else we can help connect you to in the community to help you support yourself during this challenging time? And then finally, what other considerations need to be made? You know, what's it going to look like when we do go back to the office? You know, what kind of support are people going to need when we transition to going from home back to the office in a mental and emotional capacity? You know, what do we need to do for our inpatient team and protective measures that will be important to put into place that we didn't have before because we didn't really need them as much as obviously we do now? Distancing in our current office configuration, you know, we've got 2 to an office. It's probably not 6 feet between people, you know, so what is that going to look like, and how will we shift? Will people stay at home and work? Will we, you know, stagger our team? So those are questions, you know, we'll have to answer when we get to a point where we are starting to make considerations to return back to the office. And then, you know, how will in-person sessions change? Like, what will that look like? And also, will we continue doing Zoom appointments? Because I think they can be really helpful for individuals who don't live in the area. You know, University of Michigan gets a lot of, you know, referrals from far away in Michigan, Upper Peninsula, Northern Michigan. You know, can this be something that continues to stay as part of our workflow as we offer, you know, patients and clients tobacco treatment? This is one of my favorite quotes. I wanted to throw it in so that people can see courage doesn't always roar. Sometimes courage is the quiet voice at the end of the day saying, I will try again tomorrow. I feel like this is a pretty spot on way that I often feel, and maybe others feel, that you know, we're trying our best to still do the same kind of work we were doing before, but it certainly looks different. But like Libby said, I do think that we were successful in a really swift transition. And I think we're still giving the best care that we can give it under the circumstances of how we have to, provide that care. And then this is information about me. Thank you.
Thank you, Allison, and we will shift it over to Amanda right now. Amanda, where are you? Go. Okay. Okay,
All right,
Amanda.
thanks, Paul. I'm just getting my screen up here going. Let's see if I can change it. Ah, there we go. Should be able to do my slideshow and start from there. Great. So thank you, Paul, and thank you to Libby and Allison for your wonderful comments so far. You both have such great perspectives, and you're a tough act to follow. So I would be happy to tell everyone about kind of our adaptations here at Henry Ford Health System, or should I say here in my basement, because that's where I actually am. Much like everyone else, we're very much even more telehealth centric than we were prior to COVID-19. And so we're kind of pressing on with our, building on our strengths in that area and seeing what we can achieve from there. So prior to the pandemic, we had, of course, our tobacco treatment counseling services. We had a group based in Metro Detroit, which offered the telephone-based coaching as well as in-person classes based on the Freedom from Smoking model. And then, of course, we had acquired a few years ago Henry Ford Allegiance Health, which is in Jackson, and they offered one-on-one coaching as well. I believe they were in the process of setting up some Freedom from Smoking and group-type classes when all of this kind of hit. And so both of our programs are referral-based programs. Both the telephonic and in-person types of programs are, most of our patients come to us through the EPIC electronic medical record. We have a work queue that we reach out to patients to try to enroll them in our programs. And so this is true of both the counseling or coaching by phone as well as our Freedom from Smoking classes that we had been offering in the Metro Detroit area. So when COVID-19 descended upon us all, what we have primarily seen in the past couple of months is a large reduction in outpatient visits across our health system has led to a consequent drop in referrals. So you can see, like for our Metro Detroit program, in January and February, we were well above 250 referrals each of those months. And those are definitely our, some of our biggest months of the year with New Year's resolutions and people wanting to meet their insurance plans requirements. March had sort of trended downward a little bit initially, and then there we are in April with 47 referrals coming to us in the work queue because just outpatient visits were not being done, and typically about 2/3 of our referrals come from primary care practice, as well as a bunch from specialty outpatient care like cardiology, pulmonology, those types of things. So similarly in Jackson, we saw, whereas in February they might have over 100 referrals coming in April they're down to less than 20, and that's just the fact of life at this point. I would say that like others, we have seen that those patients that do get referred to us, we have some better luck in being able to reach them. Our enrollments did not drop in quite the same consequent way as the referrals have over time. And that's because, you know, people are at home. Certainly that's a helpful factor. I think it might be a little bit of a, you know, a chance to make a social connection, you know, for people who might not have a lot of opportunities to do that. And so that by itself means that we're reaching probably a higher number of people for the number of referrals that we have, and so that's helping to kind of sustain things. We have seen kind of dual effects on people's motivation to quit. When we reach them, some are very motivated to protect their health even more because they have seen the media coverage or they've made the connection themselves that smoking is going to be a terrible idea in this era of trying to avoid a severe respiratory kind of illness. But on the negative side of things, everybody is just stressed out to the max, and it may be a very daunting prospect to face giving up tobacco at this time in history, if I might put it that way. And so, you know, it's never sort of an easy time. Many times it's not the ideal time, but it's a really tough time right now for our patients trying to deal with this addiction. And then, of course, there are these system effects that, you know, we have seen that Allison described somewhat. We had about 2,800 staff who were furloughed across all of Henry Ford Health System. That did include one of our administrative staff. And while it's, you know, the way that it was set up, I think was as kind and as transparent as it could have been, it's still, you know, a bit of a shock to the system. It does, you know, reduce our, you know, FTEs supporting the program a little bit. And so we're kind of dealing with that. You know, it's kind of matched up to the decrease in referrals. So it could be worse, but, you know, it's more the, I think the emotional toll that it takes is probably the toughest part about it as far as our program is concerned. And so, you know, we're hoping that we've been told these are temporary furloughs, that they are looking to bring back as much of the staff as possible. And so we can hope that this continues to be the case as we start to make moves toward opening back up more non-emergency and non-critical services, more elective procedures and that kind of thing. So we hope that this is, you know, more of a temporary effect, but there's no question that it puts some pressure on everybody involved. As far as what we have done to adapt to these changing circumstances, with our Metro Detroit program, we have been called upon by our own media relations department to sort of serve as a source of expertise for the media. That was one of the immediate things that I think really clicked for a lot of people, was just that, you know, this obvious connection between tobacco use and COVID-19, or at least the potential of that connection, really meant that there was a lot of media interest in that. And so we want to do our best to capitalize on that sort of thing. So, you know, I've done one radio interview, I've written a post for our Live Well blog, and just, you know, looking for other opportunities to make this part of the conversation, because we really want it to be a bit of a teachable moment. We want to take advantage of this little bit of spotlight that might serve as a driver for helping people to quit. You know, we are lucky that we are well situated as a largely telephone-based program, that our business can continue more or less as usual. You know, all of our one-on-one coaching has been delivered that way since the program was instated. And we are looking into ways to have virtual group classes or group sessions of some kind, so that we can offer that option for people who really gravitate towards that group dynamic of having the support of other people going through the same issues. You know, that's really important for some people working on quitting. So we want to try to be offering that, and offer that as another option, again, just for connecting with other people. because we're really, I think that is so much coming to the forefront as everybody's trying to be safe and trying to keep each other healthy. I've heard from my colleagues in Jackson that they are switching more of their coaching to be taking place by phone. And as far as I know, that's working fairly well. They have done some tobacco webinars as well. And they recently launched inpatient behavioral health referrals so that they can kind of get those patients who are in the greatest need and have some of the greatest difficulty to get connected to some services. And so, you know, we're seeing this as like, we were a bit lucky in that telehealth was our default mode, and so we can kind of build from that area of strength that we, you know, we were sort of already in that space. I will add, though, that we have had worked to set up the capability for video visits with our clients, and I'm not sure if it's just our particular population we're dealing with. They do tend to skew a little bit older, for example. We haven't had much interest in the video visit side of things. The telephonic style seems to suit a lot of our clientele, and so that's really, you know, what we've seen the most interest in over time. You know, offering the video side of things, for whatever reason, has not panned out terribly much. So looking ahead to what we might be seeing in the upcoming months and possibly years, I suppose, we are preparing to launch a program for teens. We have developed sort of a brief intervention where our counselors would, you know, we would receive referrals in Epic similar to how we receive them for patients aged 18 and up. And so we're working with our Department of Pediatrics to encourage them to refer their younger patients to us, ages 14 to 17, so that we can reach out to them, do a little bit of counseling by phone, and then try to connect them with some of the online programs that are offered by, you know, large nationwide kind of reputable organizations like the MDHHS My Life, My Quit program, like the American Legacy Foundation's programs, or the Truth Initiative, I should say, smokefree.gov, and so forth, you know, so that essentially we would do sort of that brief phone intervention and then say, okay, you know, what kind of follow-up would you like? Would you like it to be by text? You know, we'll certainly differentiate between if they're smoking or vaping or both, and connect them with a resource that, you know, may be more specific to that. You know, again, both we and our colleagues in Jackson are planning for virtual group classes in maybe with slightly different angles to them. I think we're looking at that more of a class format, a little bit like a quitting 101 kind of presentation to get things started. And in Jackson, there's sort of the somewhat patient-driven effort to develop virtual support groups, so a little bit of a different structure in that sense. We certainly expect to continue communicating both to promote our programs and reminding our providers to keep referring patients to us in the context of COVID-19, you know, noting how much of an effect, as we heard this morning, that smoking and vaping and other tobacco use is likely to have on people's, you know, the course of people's illnesses and so on. And then hopefully we, you know, what will things look like as we do see our outpatients return to the clinics? You know, hopefully we'll see those referrals pick back up again. It'll be interesting to know if people have, you know, either by choice or not, kind of ended up giving up their use of tobacco. But then as things open up more, how will that change? You know, it's not totally clear. But we're hoping to see, you know, a renewed flow of referrals as we figure out how to navigate seeing those patients in the outpatient setting again. And I think that's about all that I had for my presentation. I'll turn it back over to Paul to ask us questions, I guess.
Okay. So thank you so much, Amanda and Allison and Libby, all for giving us that little insight into what's going on in your worlds. If anybody has any questions for them, please just unmute your mic and ask the question to any of them. We'd also love to hear if you've had any experiences in delivering services that you would find helpful, or challenges that you're not certain how to overcome, that you would like to throw out to the group. We have about 10 minutes before the next session, so if you do have any questions or stories to share, please speak up. Okay, well, it sounds like you guys are getting off easy on the question front. Congratulations. So the next session will be Ashley Wakefield from American Cancer. We'll start that in about 10 minutes. So again, good chance to stretch your feet, stretch your legs, grab a drink, or go to the bathroom, whatever you need to do. And we will be back here in about 10 minutes.
Thank you.
Amanda or Allison or Libby, if any of you guys are still haven't walked away from your computer, Lisa asked a question about that I did not see. How are you doing your billing for these?
Say what?
How are you doing your billing for these virtual sessions?
Yeah, so at Spectrum Health, we do not bill for tobacco cessation. So that was part of our strategy in the first place, that we wanted to be able to provide this at no cost for the patient or the community member. So far we've been able to do that. And yeah, you know, who knows going forward, but I feel like I hope we're able to continue doing that and just be able to provide that support at no cost. Our primary concern was that the majority of tobacco users are oftentimes underserved, underinsured, or uninsured, and we didn't want that to be a barrier to them quitting tobacco. So
My computer is telling me that it is now 2 o'clock, so we can get started with the final presentation. Ashley from the American Cancer Society Cancer Action Network will talk a little bit about how we can continue to make sure that we are getting good policies and not losing the momentum that we had built up as a group prior to this whole COVID thing. So with that, Ashley, you are now a presenter, I think. Yep.
Hey, everybody. Let's take a look here. I'm going to get my slides to show up.
Okay. Paul, I have a little bit of an echo. Is everyone else hearing that?
I'm here.
Yeah, you seem
You're
fine.
very low one. I'm just going to mute everybody again, and that might solve it.
Okay. Okay, everybody. Well, I will get going here. I realize that I am the one standing between you and your weekend for many of you. And so I just wanted to thank you for having me, first of all, to present to you guys some of the things that we've been learning over here at the Cancer Action Network for virtual advocacy and working with volunteers. That's primarily how we advocate. But also in a world where we're just having to be very creative. So I wanted to start out with some of the challenges that we've experienced. If we could just start there, let's see. So as it's been mentioned before, some of the challenges that we find are kind of what we would say are no-brainers, right? Everyone is kind of experiencing some of these challenges themselves. Typically in the past, our advocacy efforts have been a combination of virtual already through things like social media and other things that you can do online, email advocacy, action alerts, things of that nature. But now we've had to pivot, and in large part, our biggest pivot has been our Cancer Action Day, or some of you may know it as our Lobby Day. Typically in the month of May, so we were actually supposed to be in Lansing Wednesday, and we do a Cancer Action Day where we have about 100 to 120 volunteers to send, come to Lansing, meet with their lawmakers. And what happens is we're able to really pack a lot of things into one day. And because we're building community with being together and things of that nature, it just usually has a really impactful, we have a very impactful day. So we've had to pivot that day completely virtually. And so like Paul was saying, and many of you others were echoing, we've had to try and do so while keeping the momentum and making sure that we're still moving in the right direction and having our message be heard. So some of the challenges I want to start with first, some of the challenges are obviously technology, right? So not everyone is comfortable with technology, especially if you're working with volunteers or different demographics. It's just a really big learning curve and can be really uncomfortable. Sometimes there's some issues with it that arise that you aren't able to prepare for. And so we have been finding that we've had to navigate a lot of things that we didn't really know were issues. Secondly, it kind of is the education of it all and saying and providing the right tools for people to learn and get caught up or get to a point of being comfortable with doing virtual things, like even meeting on a platform like we're doing now. And then access barriers. So as you all know, not everybody has access to some of the technology or platforms that we do. If you've been able to remain in an environment that has allowed you to have an at-home laptop or have different platforms that you are able to work with. American Cancer Society, we work with Teams, but for us, we didn't have access to things like Teams Live, which would allow us to broadcast out to a lot of people with some of the controls. And then certain organizations don't allow you to work with others due to safety concerns and keeping everyone protected and their information protected. So those are some of the baselines that we've seen, as mentioned before. Now, there have been some really incredible opportunities, though. One of the things that we have found is by pivoting virtually, it has broadened our reach, because not many people, or I shouldn't say sometimes there's some other barriers that happen when you have a Cancer Action Day or a lobby day, or you're meeting with lawmakers and it's in Lansing. Not everybody can make it. And so one bright spot in all of this has been a pivot to virtual that has allowed us to broaden our reach and broaden who we can give a voice to. And so we've been really excited to see a lot of people start to engage in our virtual advocacy that hadn't before, because they felt like, well, I live too far away from Lansing to be effective. So that has really been exciting to see how far we've been able to reach. And then it's also given us more options for connection, because everyone is pivoting virtually. And I think that's something that you all know we're all navigating, and we've all been on calls like this. And a lot of our volunteers and even people who haven't or aren't in this world and aren't in this space have been able to integrate and really jump on board. So that's been really exciting. And then it's expanded our capacity for virtual options. So we have had to quickly say, this is what we want to accomplish. How can we do so? And so our organization, other outside companies, things like that, has really given us a opportunity to expand that reach. But something to think about is, if you don't currently have a lot of virtual options set up, such as a broad-reaching Facebook page or Instagram page or Twitter followers, what we have found is that a lot of people are looking for information virtually because it's the only place that they can find it. And so our growth on those platforms on social media, subscribers to our website, we have just recently launched a podcast. All of those kind of emerging platforms have expanded because that is where people are able to find their information. So we have definitely seen a bright spot in our reach because of that. Let's see. Now I know that there's a lot of different, a lot of different industries and things like that represented here in different ways. So I wanted to go through a couple advocacy things that we have found working with volunteers or people who are not actually employed by your organization, and then I will go into some advocacy without. So there's three main points that we have with the pivot to virtual have found to be effective, or three different areas, I guess, that we've really expanded and learned from. The first one is engagement. So some of the basics of how we engage, and I'll give you just a brief rundown of how we are set up. For the Cancer Action Network, we have what we call an ACT lead, or a main volunteer, in each congressional district. So we have 14 different ACT leads throughout the state, and then most of them have what we call a deputy ACT lead, which is kind of your second in command. And then they have a team of ambassadors or other volunteers that maybe don't want a leadership role, but they're certainly willing to partake in some of our advocacy efforts. And so our goal is to just continue to expand upon that network and build our teams, but also empower our volunteers to do that so that it doesn't all fall on staff. And we're able to more effectively reach more people by doing that. So some of the basics for how we bring new volunteers in, the first thing that I usually do is connect them with their peers. So connect them to their congressional leadership and give them kind of a one-on-one conversation or even an email handshake to kind of assimilate them into, hey, here's what's going on in your part of the state. And then the next thing that we do is we connect them to their lawmaker. So that could be as simple as sending them to our lawmaker's website, finding out who actually represents them. And then I have a little postcard that I have pre-made up that they get sent. And it's basically just says, I'm here to say hello. And it's just a quick little introduction that they can send into their lawmaker, and saying, hey, I'm a new volunteer with the Cancer Action Network. I just wanted to introduce myself. And getting on their newsletters, telethon halls, things of that nature to kind of start building that relationship. Because our whole hope and what we have found with advocacy is the closer connected you are to the actual House or Senate member, the more effective your voice can be because you're actually a constituent of theirs. And then we, of course, have some built-in organizational training and things like that that we kind of walk them through. Once they're through that, we work to integrate them into kind of more consistent messaging so that they're able to hear and able to stay up on top of what's going on advocacy-wise without overwhelming. So I usually send out a weekly update to my leadership, who then picks out a few, little action alerts or things that they can do to pass on to their teams. We established different communication methods. So I think one thing with pivoting virtual is that has never been more important, is to establish how people communicate. So I'm like you, I'm working from home, and a lot of my volunteers, some don't love email, some prefer the phone, and so they have gotten my cell phone number and we stay in contact that way. Some just want to text, and that's fine. It's just kind of establishing that those lines of communication with the people who are doing the work with you and finding out what's best for their current situation. And then integrate them into building a team. So what does that look like to have others join you? And so, this is kind of some basis, I guess, of how we grow our team for volunteers. And I will say that at first, when everything hit with the pandemic and we are, shifting to all virtual, I was a little concerned that I would have a back off in involvement. And I have actually found the exact opposite, that a lot of people are looking to help where they can. There's obviously a lot of challenges that we're all facing, but people are eager to help. And so we, from a cancer perspective, cancer patients are certainly involved in a very vulnerable, group of people, especially in this current time. And so we have found our engagement has gone up because people want to engage and help. So one other thing that I wanted to point out about working with volunteers is that there are some technology gaps. Kind of mentioned this earlier, but some of the methods that I have taken and our group has taken to help with these technology gaps is repeated exposure. So again, I am guessing that this is probably not your first virtual meeting that you've been a part of. And our volunteers and people who are new to our organization, new people who want to help, things of that nature, this probably isn't theirs either. But I have found that the more you expose them and give them options to practice, the better everyone feels about it. And so we have done a few little changes in preparation for our Cancer Action Month, of making sure that our monthly calls are now on the same platform that we're going to be using in June, so that people can have some more opportunities and exposure to it. I have, written more tutorials than I think I ever have in the past couple months of how to submit a letter to the editor virtually versus, mailing it in or dropping it off in person, things of that nature, just giving them exposure to different options and letting them kind of grow with these challenges. The other thing that I've done is some people are more comfortable with technology and with these shifts. And so I have equipped some mentors to kind of help with navigating the process for some that aren't. And so that has proved to be really effective. And then in the opportunities to practice, kind of going back to that, so something that was really effective and that we're going to be implementing for our Cancer Action Month using the Teams platform is we're going to have, prior to the prior to the launch on June 1st, we're going to have 2 practice sessions for volunteers or for participants, and they will be a 2 2-hour blocks where people can log in. We will have an active meeting ongoing. They can log in and stay for 5 minutes, 10 minutes, and kind of test out some of the technology while we're there to offer help and questions and address any of the computer or muting or any of the other things that problems that could present themselves, so that people aren't trying to navigate the issues at the actual launch or on the actual webinar, but they're able to practice beforehand and kind of get a footing. So those are some things that we're doing if you are finding that you're working with people not as familiar with virtual options. And we have found them to be very effective, and people are jumping on board for that. Some tactics that we have done with our volunteers to keep them engaged virtually, obviously emailing actions out. We have a program set up where we can actually email to our volunteers or to what we deem as action takers, so people who have been involved in your issues before. And what they do is then it forwards on to their lawmaker. So I've also drafted up different tactics and emails and said, hey, could you send a quick thank you to your lawmaker? And it's really all about, building relationships. And the beauty in all this is that even from an advocacy standpoint, the lawmakers are having to pivot virtually too. They're in their own learning curve. So something that we've done to kind of bridge that gap between lawmaker and volunteers is we sent out a survey to all of the member offices, asking them if they would be open to a video conference call with constituents, or just a phone conference call, and some feedback. And so we're able to kind of just open that door of saying, hey, what are your capabilities? What are you open to with meeting with your constituents? And we received quite a few responses, and very receptive to reaching people where they're at, given social distancing. So those email actions, letters to the editors, social media engagement has really continued through all this, and like I said before, kind of has grown. And then one thing that we are finding to be kind of fun is we are doing some Facebook Live panels. So and I'll speak a little bit about what's happening with our Cancer Action Month in a few minutes, but you can see this graphic here, the devil's in the details. So this was actually surrounding the package of tobacco legislation that Jared spoke about earlier in the day. This was one of the social media graphics that went out to our network, and it had a bunch of engagements, and it was linked. So in the actual description, it was linked to our action alert, so people were able to email directly to their lawmaker from this social media platform. And so we have found it to be really, really effective at reaching, new people. And like I said, everyone is on technology right now, or for the most part, they're having to pivot that way. So our reach has been broadened. And with back to kind of the Facebook Live panels, is we're having in our, sorry about that, in our Cancer Action Month, we are going to have a live panel with a couple lawmakers outlining some of the issue platforms. So we're still working on a team for our tobacco ask, but we will have an entire week in June devoted to tobacco issues. And so part of that will have kind of a live panel where we'll be engaging people right then and there to ask, answer questions, things of that nature. So like I said, there's a lot of different creative ways. This has certainly opened the door for creativity. I wish it was under better circumstances, but nonetheless, we're moving forward. Now, just briefly to go through some tactics that we can have for advocating without volunteers. Let's see if my slide will move here. So relationship building obviously has been really big and has taken on some new roles. I've had more virtual handshakes via email than I think I ever have in my life before. And then building coalitions, kind of what Jared spoke about, but it's also a really good time because people are wanting to learn from one another, and you're able to kind of get a broader view of that. So with relationship building, like I mentioned before, lawmakers are learning too. So we have found them to be very open to new forms of communication. So if you haven't before, why not now? That's kind of what the tactic we've taken, and it has been really effective. And then also we have found, and I have found, that there's a lot of other organizations and structures already moving forward. You've heard from some prior to me of how everyone else is pivoting virtually. And so it's been really nice to there's been a lot more collaboration amongst different organizations, and people have been kind of jumping onto other efforts. So we have certainly seen with Arms Wide Open, other coalitions join into our virtual Cancer Action Month. They've had their members register to join us. And so that's been really encouraging to see all the collaboration happening amongst groups. And then, as you guys are familiar with the coalition building, it furthers your reach, obviously, because you just have more people, more networks of people that you're all able to move forward. I mentioned virtual handshakes, everyone's doing it. So now is a great time to reach out to those who you would like to work with. It's been very effective. And then also we're able to see the broader view of the issue. So the Tobacco Coalition, the Keep My Kids Tobacco Free, has, as you saw, so many great organizations moving in the same direction, but we're also able to see kind of where everybody's at and then find the best path forward. So those have been some really big bright spots for, in the virtual world that we've been forced to find ourselves in. Now, I wanted to speak briefly about our virtual lobby day or our virtual Cancer Action Month. And as an offering, you're more than welcome to join us for this. And actually today is the last day to register for our Cancer Action Month. So I have that link down at the bottom. You can just put in your information there. It does have a section where you can say which organization that you are representing, and you can take part in as much or as little as you'd like. Obviously, our advocacy efforts are focused on cancer-related issues, but like I said, we have a whole week devoted to tobacco and what's happening in the state of Michigan. So some of our advocacy efforts during that month. So what is that going to look like? Like I said, we're separating into weeks. So the first week, we're going to be focusing on our oral chemo ask, which is very specific to cancer. But that is going to be, we're going to have an email going out to every participant for them to email directly to their lawmaker each week. There will be some social media presence for sharing and engaging lawmakers on Facebook and Twitter. We'll have a live Facebook Live panel each week detailing the issues. We're having a kickoff webinar where we'll have guest speakers, and it'll only last an hour, but it'll kind of outline how our month is going to go and outline the details. What I have done to prepare people who are registering and our volunteers and other coalition members is we are going to have a new volunteer orientation. So it'll be on a virtual call much like this to get everybody comfortable, where you'll be able to answer questions, things of that nature. And then we are going to be setting up either a video conference or just a telephone conference call with the lawmaker's office. So for tobacco, we will be meeting with the Senate offices. It's also presented us for the nonprofit world an opportunity for some fun and creative fundraising options. So that's been really interesting to explore, such as like a silent auction and some of the other efforts that we're doing. And then, like I mentioned before, some of the things that we have learned through all this is how to troubleshoot. And a lot of that entails, having a lot of practice sessions, a lot of immersion into our technology world, and then offering a lot of information. So when you're doing something like this, especially involving people who aren't familiar with your platform, we will have a page on our website completely devoted to our Cancer Action Month, where it'll have resources for people to help, and then also connecting people who may not be comfortable with a mentor. We will have a pre-event survey going out to try and get ahead of where people are concerned. So it has on there, are you concerned with, how to use Teams? Are you concerned with sending an email? Are you concerned with, who do I ask if I have trouble? Things like that, to kind of preemptively deal with some of the technology barriers that we're anticipating to find. So I think I may have given you back a few moments of your afternoon, but I did want to open it up if anybody has any questions or anything about some of our virtual advocacy efforts, or if you'd like to join us, arms wide open for you to partner with us during our Cancer Action Month. That is going to be taking place in June, and my email is on the screen. So if you'd like to connect outside of here, I am always available. So again, Paul, thanks for having me. It's so great to be with all you guys today.
Thank you, Ashley. And we got somebody in the chat. Just Cliff says thank you. Any questions for Ashley?
Hey, Paul, this is Ken Fletcher at the American Lung.
Hi, Ken.
Hey there, I'll just add to what Ashley said. At the Lung Association, we've tried a similar thing in terms of virtual advocacy. Instead of our Washington, D.C. advocacy trip in March, we ended up doing it all, through Zoom and Skype calls. And, it actually worked out fairly well. We ended up having, representatives from all across the country, all talking to members of the Senate and Congress, had some real good conversations. It certainly isn't the same as all getting together and that camaraderie and everything that you do from having advocacy days and stuff. But actually, we got some good stuff accomplished by, having the conversations and dialogue. So just wanted to add that to encourage others that it certainly is worthwhile doing to try to reach out and schedule some of this stuff and to make it happen.
Thanks, Ken. I appreciate that. It's always good to hear people who have gone before us as we're, crossing our fingers and hoping for the best. So that's really encouraging. I appreciate that.
I'll also add that if you aren't signed up for the Tobacco Free Michigan updates that go out every couple of weeks, do consider signing up for those. We promote the virtual advocacy days and other advocacy days and ways to get involved throughout the year so that you can see what the opportunities are out there. So just a little self-plug there. Any other questions? In that case, I think we can call this thing done a half hour early. Thank you so much to everybody that presented: Ashley, Amanda, Elaine, Allison, Jared. I think the presentations went extremely well. I will be sending out a follow-up probably on Monday because I'm still waiting on one of the presentations with links to all of these presentations. Everything is recorded. So once I get those links from GoToMeeting, I'll get those out to you. In the email, there will be a little survey to try to get some feedback on what went well, what didn't, as well as if you guys need any of those continuing education credits, information on how to make sure I can get you exactly what you need for those. So please watch your mailbox, hopefully on Monday. Some of you said it went to spam, so if you don't get something, check your spam. Or just shoot me off an email at tfm@tobaccofreemichigan.org directly, and I will send it to you that way. But I would just really like to thank everybody for coming. I'd like to thank the board again for all of their help, and all of our membership and the Michigan Tobacco section of Health and Human Services for providing the funding so that we could make this happen. I hope we can make this happen in real life next year.